team, and we're able to continue passing out the information, immunizations, when they'll be held, and so it is continuous. From the onset of the COVID pandemic to this day, we still work with the DHEs. I think I have one of them here. And we work with them on different occasions to make sure that we're passing out information about COVID, how people can prevent it.
Thank you so much. When it comes to the mandate and the main objective of ensuring that to have a free family planning process, you are doing well. But I'm seeing an element where you have not adjusted to the current. The current situation as of now is all of us, we are joining our hands together to ensure that we fight against the COVID-19 pandemic. And that's now. So I anticipate that with all your successes and your journey and efforts, which 100% you have done well and you are still doing well, you must be focused now and bring on board new programs. When you are see leave no one behind, social behavior change in communities. During this time of the pandemic, the social behavior in our communities has completely gone down because we locked them. The government locked them. They locked down, which was not our intention, of course. That was one way that we should go through this pandemic. Made sure that the families are locked inside their homes. Take an example where my good friend and in-law comes from in Kawai. When you lock the mother and the man and wife in their homes, the expectation he knows better than me. Yeah. So how are you addressing that? Because they have now too much time of doing nothing and they are locked together. And you know, when people stay together for a long time, that attraction makes them to continue now. So you may be looking at family planning, but this time when you go down on the ground, you might see that there is a difference that it is going up again. The drunkenness in homes, definitely. Even where you find in urban people just seated and drinking and on your road. That one also you need to address. How do we address? You know, this time we must focus to see in this area, yes, but now where we are going, what is on the ground, we should refocus and redirect our programs to the situations on the ground. So I find that one also. Home-based violence, it's high. So that as the people who are doing so much and are doing so much in communities, this is where you need to engage them, our distressed people, the VHTs, the information about vaccination, about SOPs. You have a lot now to take out with this megaphone. You see, we will not only focus now on saying, you know, we are controlling family planning when the other area is at high risk. Polio, there is a threat of polio now. We are moving towards mass vaccination against polio, I think in 2 weeks' time. And this is your area that you should be at the forefront. I'm saying forefront because you have been in the communities and you are still in the communities, and your partnership with the Ministry of Health and the government really will help us so much. But otherwise, we are very grateful. We need to focus and we move. Once we are stable, we again go back and tell them, okay, one person, one child, 4, 3. But now there is enough time for them to do nothing, and they do nothing. The attraction is something else. So if we can also refocus our programs, move together, down now, people coming out for mass vaccination. We have the vaccines, the people are not coming out. We need people like you to help us and ensure that we are there to mobilize these people to come out. And at least we have our 22 million vaccinated. But so far, thank you so much.
This stall is about our partnership with the private sector. So we work with several private clinics, drug shops, again to extend access
Fred over here is going to take us through. Fred, the Honourable Minister is interested in what we're doing in the private sector, but also how we're supporting the current situation, increasing teenage pregnancy and the COVID response. So over to you, Fred.
Honourable Minister and dear guest, I'm really excited to introduce to you how we do work with the private sector. It's a public secret. Over 68% of the persons, you and I, when we are not feeling well, the first place we go to is the private sector. And that's a niche which tend to be by themselves. You wake up, put up a clinic yourself, fragmented, low scales, not much money you have, the quality is not well regulated. So we found it prudent that if we want to make a deeper reach and to strengthen the system, that we need to strengthen the public and the private sector partnership. And we are the broker as Milestone. So what we went out is to identify, support them in terms of quality, support them in terms of business growth, but also in the same way as we are supporting their business growth, we are ensuring they are able to access to provide clients with the quality of the services. We do have the two arms of the segment. We have the private clinic standalone, but we do have the private midwives who are working within the community, well equipped to provide the services. And doing this, they are able to reach out to the segment where we do have. With support from donor, DFID, and previously you said, we had a voucher program. We know in the private sector, somebody puts stuff there to make some money. Nevertheless, you cannot be there to be provide free services. But we do have the segment of the population who might want to seek the service from the private sector, but they cannot afford to pay. And that's where we got the funding from the DFID, who provide us with a voucher. We have two categories of the voucher. We have the hardship voucher, where the adult person can be able to get a voucher from the community-based mobilizers who identify who is poor and eligible to provide the services, or a peer mobilizer who are able to identify the young person who wants the services. And it goes out to identify them, provide them the voucher, and use that voucher to go to the accredited sites. And those are the 220, but the number keeps on fluctuating. Because as we start you on the journey, you are at a lower level. But as you continue growing your muscles in terms of business growth and productivity, we graduate you off, and then we onboard other facilities. Currently, we have 150 facilities which are providing the services. In doing so, we are able to reach the young persons. In doing so, we are able to reach the poor. But also, don't forget, we tend to forget about those who have people who are here. We tend to think that for them, they don't want the services. And most of them, they tend to go to the private sector. So we have strengthened between the public and the private. Initially, before we started working with them, they were struggling to capture the data from the clients. And because their data was not being captured, they couldn't understand what they are doing. So we supported them. Now they are able to capture the data. They are able to report the data. And you can be able to track the impact of the private sector which you are working with. And that's what we've been able to achieve. We have the proprietors, the owner of the business, who can give testimonies where they were and where they've reached. But we have the CBD who go out there to mobilize. We found very important doing the COVID era, because the private sector is within the community. We found it, among the services which were closed, the health service was not closed. But what we know, the private sector is within the community. So we went deliberately, purposively, to incorporate the COVID messaging when we are mobilizing family planning services. But also we have supported, Adrian can attest, they've been accurate. Some of them are vaccination centers, some of them even they go ahead to treat the COVID in their locations. So that's how we do strengthen them as we work with them. So we are looking at the future. How can we scale up more? Because we know we have so many private facilities. We cannot do it alone. And the only way is strengthen. How do we work with the government? How do we strengthen the public relationship so that they can continue moving on and delivering to the scale?
Thank you. I want to start from there, but first of all, I want to thank you so much for the good partnership that as a government we have with the private sector. Yes, absolutely. Every sector government, there must be partnership of some kind with the private sector. I want also to appreciate your last where you said how we in the future, or from now on, or from where we have been, how do we partnership with the public health system, and especially during this time of the pandemic. My concern, however, I I came in at a time when the pandemic had just started. But the experience and the public outcry was that the private health practitioners took it up that it was time for them to make business. So that's what I wanted to hear. But when it came at a time when those poor you are trying to work for, to talk for, to reach out, to give them to the voucher, when the prices of those that were affected by the pandemic, by the COVID, accelerated to the sky, how did you come out to reach to those people? It has been a very big and unfortunate way of dealing with things. You say, and we are aware, and I'm aware that the private sector definitely is there to make money, but it's not to make money or business out of a catastrophe. So that area in the future, because COVID is still with us and other pandemics will come over, try to look into it and see how you can partner with us as a government to ensure that the public, our advance should be to save a life, especially in such a critical circumstances. Then the next will come up. Definitely you can make money to sustain, but it's time where you say now it is an area we should partner with the public health facilities. There are too many private clinics coming out in the communities, and their costs are extremely high. And say, no, our services are better. Yes, you're supposed to give better services. You're not supposed to say, my services are better, I therefore have to put my charges high. You are also says you must give very quality services to your perfection. So when you are charging because this is better, and when in the better the prescription is a Panadol, and it is a 10,000, where in the other place it is a Panadol. Same treatment, Panadol. There 10,000, here it is 3,000. But thank you so much. In the future we are going to sit together and see how we can continue. But we are very grateful as government, as the ministry, for the partnership we are having. Only if we could bring together for our communities, especially the poor and the rural, to get quality and cheap service. Thank you so much.
Honorable Minister, these are our private clinics and maternity, but I'm going to move you ahead so we talk at one point. So these are Maristo's own private health facilities. And Christopher here will share a bit what the broad vision is and how they support all of our services. The minister is interested to hear what you're doing.
This side of course. These ones I'm seeing them.
Thank you very much. Country Director mentioned we operate a number of private clinics. We right now are testing COVID, and we're managing mild cases as well. On top of all the other services that we provide, we also offer services that are subsidized. We subsidize especially our core services, which are family planning, cervical cancer screening, and post-abortion care. The subsidies especially goes to ensuring that we meet our running costs. And this is how we fit into the wider Maristo's
Honorable Minister, I think I'm going to move you along. These two channels are our focus. The public sector, DHT work, the poor and the hard to reach.
That's why I'm moving now.
Yes,
Open
some
it
of
up.
these questions will be answered here. So this is our outreach team. Outreach involves a band driving through and reaching hard to reach and underserved populations. Dr. Stephen Mutegeki is the head of outreach. Stephen, the Honorable Minister wants to hear how you've integrated COVID-19 response into your work, how you experienced the teenage pregnancy epidemic and how you're responding, and how you're supporting the DHT structure to deliver these services and deliver COVID messaging.
And the hard to reach areas or communities. My constituency,
Zimbabwe.
yes. The farthest is hard to reach.
Yes.
Have you tried to reach there?
Yes.
Go
Yes,
on, Stephen.
thank you very much, Honorable Minister. First of all, thank you for making time to come here and having an experience of what Maristops does. So this is the outreach channel. What outreach does is to go where no one else dares to go. We have a number of service vans that carry a mobile clinic to deliver services to the most impoverished communities in this country. So as far as COVID-19 is concerned, our vans are mounted with megaphones. When the team is moving into the community, in addition to sharing messages about sexual reproductive health,
How many districts have you been in so far?
all the districts in the country,
In the same
outreach
which area did you go to?
offers services in all the districts.
In the same where did you go to?
In Zimbabwe, all the constituencies. Zimbabwe.
I'll come next time.
So here, standing behind the show is this is the public sector support channel where we support and let the public system do their work. Martin over there is the head of the channel. Martin, please come. Speak up. The minister wants to hear. Have you been to Zimbabwe? When are you going? If you
When you
haven't,
tell me something, then I move on another.
she wants to hear how you're
Because
integrating.
I'm conversant with such some communities.
Yes, and what you're doing for the COVID response, and go on.
Most welcome, Minister. So, public sector strengthening is a channel that works within the government structure to build the capacity of public health workers with focus on stock management, clinical aspect, and also data quality management. We have a team of regional trainers who are MSF staff, but they work so closely with the district trainer and also the mentees, all the public health workers, and the people they focus on to build their capacity, improve clinical quality, data quality, and stock management. So around here we have a team of experts who can explain to us what they do on a daily basis and how they do it and what is the impact.
You know, maybe I could ask in one area. My one area of focus is data collecting and data training. So during this time of the pandemic, you know, we are so much emphasis is put on data collection so that we know so far how many accumulative cases, those that have recovered, those that have died, and see all these are factors of the list.
Yes.
So now, how are you working with for example, our district health officers to ensure that the data system, the data keeping, data collection, which comes from the community, you know, because what I know is Maristops is so much interested in communities. So as you are doing this work, I don't think you are focused on in one area. No. Now that is our interest is where we are now, our challenge is within the data collection, data maintenance, data forwarding. So how are you collaborating with them? Are you training them? Have a program training them? Have you reached them? I know that this is 136, that's why I couldn't agree with him, but in this case, right, you can be 136. I wanted him to say that currently we are doing it, so there is some focus on ground. So where are you now? I'm seeing much of us is training, collaboration of the Ministry of Health, strengthening our health system, but where we are now, I mean, there is a big gap in data collection, data forwarding, data recording. Even when I look at this book, she looked at there, you find something is missing the data. So the manual and the others are electronic, you find them together. The moment your data is completely not getting, so we are lost. And that is why you find you are capturing different figures and which figures are possible collaborating pictures. How I do that, just only in that line. The rest I know you are doing that work. But as of now, our current focus and situation is dealing with this COVID and our data collection as a ministry. I found that is one thing, especially getting it from the communities. And these are where the PhDs are. These are where your other people are. So we want strengthening work together to ensure that you focus at least as an additional contribution to strengthen data systems.
So when COVID came, of course, there were a lot of challenges that we faced, and of course we had to adapt with COVID situation and change the way things were being done. So when it comes to data collection, we worked so closely with the various facility data collectors, more especially the records persons facility, right away from referral. Okay, when a client is identified in the community, when a client works in the facility, is assessed, and after assessment, when a sample is taken, that is coded in the algorithm within the HMS to capture data from patients and clients. So at the end of the day, we ensure that that data is well captured and reported within the HMS2. It feeds in the DHS2 of the district. So that's how we have built the capacity at this specific level to ensure that whichever client is identified who is suspected COVID or is confirmed COVID is documented and reported within the HMS2 that feeds the district and informs decision makers, district and
We can rush in with the we have to.
I appreciate that.
Yes. This is what we're talking about data. M&E lot is where I come from. I have put it here is the answer. We are saying that we need data every single day, especially when we have to deal with and then all the data, especially how we relate data to ensure that we work together with the Ministry of Health to help us ensure that we have correct data collected is the right data and within our system. 1 minute will be good. Otherwise, thank you.
1 minute. Thank you very much, Minister, and for coming to our booth. I'll introduce myself. I'm Andrew Gidodu. I lead the research, monitoring, and evaluation team. My colleague. But I want to go direct to what the minister is asking. How do we improve the quality of the data that's coming in from market stops to the national level? And like you said, it will improve on the decisions that are made. Internally, we have what we call the minimum standards on how we focus on improving the quality. These standards are summarized at 4 levels. Basically, it's recording. What do we do to ensure that the number is correct? Assessing what has been recorded already. Reporting, now that comes in, what number is being recorded from down there, and analyzing. Any number that's going to go through the national system, that is the HMIS or the DJS2, the first point is to have voluntary consent. We are in the business of family planning, and we know this is something that a woman or a gentleman should voluntarily consent. Once that number has been recorded in the voluntary consent form, then it can go to the HMIS register. That's a family planning. From the family planning register, it now goes to the DHIS2. How do we check the quality of that number? The subsidiary points here have what we call a routine spot check. They go back after reporting at the end of the month. Look at what was reported. Do we have the consent form? Was that the same number reported in the register? Was that the same number reported in the DHIS2? Should there be any variance? And internally, we have the minimum standards. A variance of 0 to 4, we take that as good. We support the facility to improve. A variance of 5 to 8, it's worrying. From what was recorded and reported. Then anything above 9, now the second layer, that is us, the M&E team, will go in for detailed support. With that, the Minister can give you assurance that the information that's coming in from the very least level of service delivery is verified by the teams that conduct the routine checks and us, the M&E. I want to end by managing the minute here, that when you look at this, for the different quarters in the year, I'll give you assurance, Minister, from the public sector and all the teams. The data is of good quality. Throughout quarter 1, it was low risk, quarter 2, low risk, quarter 3, low risk, meaning it's within the dimensions that we have in place.
Thank you so much. The DP standard system guidance answered my first question.
Thank you very much.
The spot check tracker answered the last question.
Thank you.
That's
You're welcome. Thank you.
Quality assurance. When you consider all of our service delivery points, on any one day, if each of our service delivery points is only one client, we will serve 700 people. So Dr. Uhuru here heads our clinical quality team, and in a minute we will tell you how we ensure that these 700 people are safe every day.
Honorable Minister, you are welcome. We ensure quality so that we provide client-centered care, safe, effective, and efficient. How do you monitor this? In our provision of services, there are inherent risks. There are incidences which may occur as a result of providing services. We ensure that all these incidences are captured live and reported within 24 hours of occurrence of services. We handle the incidences at our own cost and then give feedback to the providers where the incidents have been coming from in such a way that we ensure that our services are really safe and clean. How do we achieve this? We have invested a lot in training our service providers. Classroom training, on-job mentorship, we have invested a lot. All service providers who are providing services categorize them as competence level 1.
You have answered that. Capacity building, which is training, and all. Thank you.
This is social marketing. Anytime we talk about reproductive health, because the word health is in there, we talk about weight. But people who need reproductive health are not sick. So we find services in places outside the hospital, and our social marketing arm is one of those places. What you hear is our director of social business, and we will be one minute to tell you what social marketing is about.
Yeah, thank you so much, Honorable Minister. So social marketing, as you know, 60% of Ugandans, when they fall sick or they want a product, they first go to the nearest drugstore or pharmacy. And also the biggest challenge we have with utilization of family commodities and productive health in general is information and also access to products. So social marketing comes in for cost recovery of the organization. It is a strategy for sustainability of the organization. Other channels that you have seen are largely dependent on donors. This one we charge. But we can't go everywhere. So we work with pharmacies, we operate a distribution model, work with big pharmacies on William Street, and then our team goes on ground to create demand and market products. So we have medical detailers who talk about the products, give out information. Also we have the sales executive that manage sales. We have a continuum of care or contact center. We know that when products codes. Sometimes clients do not know how to use them. And these are tools that we have. So every product that is bought, the pharmacies that work with, they are registered on a certain system or platform called market system. And then the contact center has counselors that have understanding of these products. For every information that the client wants, they are in touch with the contact center that has counselors. This is one of the counselors. So the client is able to use the product very well. In case they get side effects or complications, they are referred to any of our structures.
Okay. Using the product, sometimes I read something about some of your products are found their way in Paradise.
Yes.
Yes, it was an allegation. I don't want to say I confirm it. Now, you marketed, it reached there. But did you take up time to reach out to the user?
Yes. Yes, so we talked about the two batches that...
You did. You went there.
We have done the work, Honorable Minister. We have done the work with all stakeholders, starting with Minister of Health, who's expected to safeguard clients, the National Health Authority, and with our clients. That incident happened in November of 2019. Condom was off the market for a couple of months, but I'm happy to report to you that this year, 2021, it's been back on the market. We've engaged the clients, and so far they have consumed 8 million pieces. Thank you very much. Honorable Minister, we have a contact center. This is the phone call center currently. Violet, over here, it's the contact center. Violet, the Honorable Minister would just like to hear how you supported the COVID response through your contact center. How you're continuing to support it.
We're still supporting it by giving counseling to the clients that call in, connecting them to referral facilities, and giving them the information, also linking the Ministry of Health, so they can reach these people. But the response team can reach them.
At the peak of the initial crisis in 2020, our contact center was listed as the Ministry of Health contact center, and we had dedicated staff just doing the COVID work.
Thank you so much.
We also do the partnerships because we know we need to work with our partners to deliver. And we're working a lot with the Ministry of Health on several advocacy initiatives, including supporting the review of the ongoing policies at the moment. I've been working with the NDR, the National Health Insurance Bill, with the Health Committee. So we have a package for you.
Thank you so much, and thank you for the good service you are doing. The partnership with the ministry. I highly appreciate all the effort.
Members, can we get back to our seats and we continue with our program? Members in the backyard, can we get back to our seats and we go through our program? At this moment, I'm going to invite the Country Director, Maristops, Dr. Carol Sechimpi, to take us through the Maristops Strategy 2030, but at the same time, invite our Honorable Minister to give us some remarks. Welcome, Dr. Carol.
Good morning. I'm seeking your attention. I see there's a bit of activity at the booth. I appreciate your interest. Let's focus here for a moment. These booths will be there until late in the evening. Honorable Minister of Health in charge of general duties, the Director General National Population Council, commissioners and other representatives from Ministry of Health, donor representatives, partners, ladies and gentlemen, all protocol observed, you're most welcome to this event. Today is our partnership day, and what we aim to achieve today is, first of all, share who Maristops is about. Because we do work in so many places, in so many different ways, I have found through my engagement with several partners that people seem to have a bit of knowledge about Maristops, but not the entire picture. So I'm hoping that out of this engagement, we will have a clear understanding of what the Maristops operation is about. So I want to take this opportunity to present to you about our strategy to 2030, and that also should cement your understanding of why we're here, what we're doing, and how we plan to do it. Next slide. So a little bit about Maristops. Maristops is an international NGO. We're part of the MSI partnership that is headquartered in London and is present in 37 countries. I'm hearing a bit of noise. Our mission is children by choice and not chance. And that statement tends to scare some people. But basically it is to say that we would like a world where every birth is wanted, and this can be achieved by empowering women and men to choose the number and timing of their births. We have 3 key intervention areas: family planning, post-abortion care, and maternity. And Honorable Minister, I take note of all the feedback you've given us, and we'll be working to continue integrating the COVID response and other matters of national importance as they arise in our activities. Last year, 2020, 2021 is not yet complete, so we're referring to last year. Last year, we did that amount of work. Cumulatively, there are 1.8 million Ugandans who are using a method of family planning provided by Maristops. And specifically in 2020, we delivered 1.7 million couple years of protection. And beyond counting the number of what is the implication of costs saved in direct health care and maternal deaths averted. Next slide. What I just showed you looks big, but we have a very bold vision. Our vision is that by 2030, no abortion will be unsafe, and every individual who wants a contraception method will receive it. That is our vision. It's a global vision. And I would like to add a caveat to no abortion will be unsafe to the legal regulatory framework for the varied countries. We know what the Ugandan ones are. So how do we plan to achieve this? Next slide. Our strategy to 2030 is a 6-pillar strategy. And it has 3 access pillars, the ones in yellow, and 3 enabling pillars, the ones in green. Our first access pillar, next slide, is that we will leave no one behind. Honorable Minister, you visited the stall on outreach and how they reached, they had to reach, and the most poor. You saw the presentation on the youth, you saw the presentation on the public sector. Our aim is to go beyond the last mile, to deliver services to those who need them the most, and we have a strong focus on the poor and the youth. We are working very hard to establish public sector models that are sustainable, and our ultimate goal is really to see a situation where all of family planning is being accessed by Ugandans through the public sector, because we know that that is what is sustainable. Next slide. We have discussed that about 68% of Ugandans' first contact with the health system is through the private sector. So if we're serious about universal access to sexual reproductive health, we cannot work outside the private sector. Newly established maternity and our franchise partners to deliver services through the private sector. Next slide is about client-powered SRHR, and that is really social marketing and putting power in the hands of women. We have seen the stall with all of our products which can easily be picked by women and men off the counter. And this is really in response to how the way people are consuming health is changing, adapting to the growing technology, adapting to the demand for self-care. And we believe that as health providers, if we don't change with the times, then we miss the mark of reaching our people. So we're changing accordingly. Next slide. We recognize, though, that we cannot do this alone, and we need resources to deliver this mission. So our mission must be funded, Honorable Minister. We have had partnerships in the past with Ministry of Health directly funding us to deliver services, and we appreciate that and look forward to a recurrence. I would like to take this opportunity to acknowledge our donors in the room. Our largest donors are the Government of the United Kingdom and the United Nations Population Fund, but there are several others. Bergstrom Foundation is in the room. So without funding, we cannot deliver these services, especially to the segment that is poor and hard to reach. But we're doing the work to diversify our funding bases, and that's why in the room we have some unusual partners, like the banks, the Totals, because Toyota, we're trying to interest them in, extending some of their corporate social responsibility investment in some of this work. And then also as we are growing our social business through our centers and our maternity, trying to deliver a high quality service at cost recovery, and then ensuring that any surpluses are invested to support those that cannot afford. The next enabling pillar is on partnerships and advocacy. I cannot overstate this one, and it's the reason we're seated in this room. Maristops recognizes that it is impossible to deliver this mission on our own. We need all sorts of partners. And that's why we're in this room sharing our mission and calling upon you to pick interest and partner with us to deliver this. And last but not least is people. People are our biggest resource, and we acknowledge them. We want to be a transformative organization. We want to take advantage of the expertise that is in our country. We are conscious of inclusion and diversity. And the big thing these days, especially with our partners and us as an institution, is safeguarding, making sure that women and men are safe from any form of harassment, whether it is in the workplace or it is in service delivery. Next. And again, to summarize our strategy, there it is. 3 access pillars in yellow and 3 enabling pillars in green. I thank you very much. So with that update on our strategy, I first of all want us to give a round of applause to the Honorable Minister for visiting each one of these booths. At some point I got nervous. I'm like, Honorable Minister, the time. But she said, no, I have to visit each one of these and understand what you're doing. And she has made comments and we've taken note of them. So, but now I want to invite the Honorable Minister to come and give her remarks, and we look forward to that advice. You're welcome, Madam.
Thank you so much, ED Maristops Uganda, and the representatives from all embassies and the consulates present here. I've seen my colleagues, members of parliament present here, the Director General, Health Councils, UN and WHO representatives present here, the country director of Maristops Uganda, who is the reason, and the family team of Mighty Stops present here while we are here, representatives from donor organizations, our very good partners, those from the private sector and insurance companies present here, my colleagues and family from the Ministry of Health, all the health officers, especially those from the district who are present here, NGOs present, members of the press, distinguished ladies and gentlemen, good morning to you all. You see, when I came here, I first did a sanitization, which was the reason that each of us must be conscious of what is currently the situation on the ground. You don't take a chance to imagine that everybody is safe. You are safe when I'm safe. And we know the reasons why one must be safe and ensure that others are safe. Is first of all to adhere and recognize the SOPs and other presidential directives. And I want to thank you, the organizers, but so far so good what I'm recognizing. Other than the few I'm seeing, their masks are not on their mouth and their nose. So when I'm always out, I take keen interest to see what is happening around me. The next is that we need all of us to be vaccinated by now. And I'm sure we have gone through the first jab, the second jab. It's a preventive measure. And why we are doing all of this is because the Mighty Stops Uganda is at the forefront to ensure that we go through this pandemic together and we fight as the services that are focused more so throughout the whole country, advocacy, giving out information, and ensuring that we have a healthy community. So I want to thank you all. It's with my pleasure that I join all of you today here for the Mighty Stops Partnership Day organized and the theme being sexual reproductive health services post the COVID-19. You have seen that I've been keen wherever each store that I visited, I would want to know an element of COVID-19 because this is what is our purpose to being here today. I didn't want us to lose focus on what is our theme, and I'm happy that those who are manning the stores, especially the team leaders, you did your best. Thank you so much. I want to appreciate the organizers, Madam Edie, Mary Stops, Executive Director, and your team. I know to reach here. Today you are showcasing the journey, where you have come from, where you are, and where you want to go. And I am very optimistic that so far, so good, the results that you are showcasing have an element which brings that there is teamwork and your supplementary to ensure good qualitative health services in this country. You have put an effort, you have put a hand to ensure that this country's health system goes a milestone ahead, and I want to thank you for that. I definitely want to thank the organizers. Had you not been here for this purpose, we wouldn't be here today. But let's join our hands all together to thank those that have manned the stores and have showcased what they are doing in our communities. This is practical, and it is a message that all of us, we do highly appreciate that at least there are some people, some citizens, some concerned partnerships that are here to partner with the government through the Ministry of Health to ensure that there is service delivery, especially to those that the services are not easily to reach in our communities. I thank you so much, and I encourage you to continue. And I want to say that I don't have to forget those ones that have enabled you, the donors, our partners, our funders, to reach where you are. Wherever you wake up, ensure that there is accountability for every penny which is put to you to ensure that this service is done, and accountability is at the forefront, and to ensure that in the future all of us, we are happy of what we are doing to our people, to our population. Once again, thank you so much. As I had said, that the theme is saying a focus on sexual reproductive health service post-COVID-19. We all know and we are aware what is happening in our communities, especially during this time of the lockdowns, especially the time where all our schools, adolescent school, child going, being sent home. An issue that I have discussed privately in short waves with the country representative of Muddy Stops is that the pandemic has exposed us, I mean everybody here and those who are not here with us but we represent today, that the mandate, the responsibility of parenthood has been neglected. There is a high increase in the child pregnancy during this pandemic. I recognize you, my dear. And it's a very concern of everybody that even you hear that some of our parents are outside outcrying, open the schools. Yes, they want the students to go back to the schools, but some of us in coma, we think they also want to run away from their parenting responsibilities. They want to send our children back to the schools and give responsibility to the school management, because the time they have been with them, they have had enough. So we must focus on parenting. Parenthood now must be in our activities. When we are talking about family planning, yes, that's high on the agenda, but parenthood is really back to zero. All of us who came from where we came through parenting by our mothers and our grandmothers, you can tell that there is a high difference from that. So I want to encourage you, those in the communities, that please incorporate the activity of parenthood, the responsibilities of our parents, especially when it comes to taking care of these adolescent age. And COVID-19 has globally impacted on all areas of maternal, neonatal, and child health outcomes. Uganda has not been spared, and this is where largely I'm seeing that Mary Stops is also putting much focus to ensure that they join in the fight of COVID-19, to ensure that all other areas of sectors, once they are together, we can get through this pandemic and achieve our objective. However, high death toll from the COVID-19 that other nations have gone through, our country, Uganda, has not reached to that level. But it's not one aspect that we should celebrate. It's one that encourages us and gives us hope that we should work stronger and stronger. We are still at COVID, second wave of COVID. Other countries have gone through the fourth wave. But we are worried that another wave may come in as we relax. You know, the moment we relax, which happened in the first wave, that's why we went to the second wave. Now where everybody is saying things are back to normal, the more you relax, the effects that will come out of that relaxation is not good. And currently as a ministry, we are carrying out massive vaccination, region by region. We are in Teso and Lango, we are moving to Acholi, and we go to Kigezi. Those areas, we are very worried as a ministry that they are blacklisted as cases that may usher us into another wave. So I want to ask you and everybody here to be our advocates, to ensure that we reach out to the communities and tell them that, yes, you are only safe when I am safe, when your neighbor is safe, when everybody is safe. Having said that, I want us to recognize that with the maternal mortality ratio of 336 deaths per 100,000 live births, approximately 15 pregnant women in Uganda continue to die every day. This is very worrying. It's very worrying, especially that when you see at this high rate of the death ratio, which should arise from preventable causes that include obstetric, hemorrhage, hypertensive disorder, sepsis, and unsafe abortions. I am happy when the executive country representative said that the projection is to show that in a few years to come, the issue of unsafe abortions will not be there. You have our support, and we shall work together to ensure that you reach to your goal. There is a glaring disparity between the rate of child and maternal deaths across Uganda acts now. We have the tools and knowledge to change that trajectory, to bring an end to preventable deaths with greater participation of all partners and stakeholders, a change in focus and commitment to hold ourselves accountable. And from all the stories I've seen the main objective is towards this goal. And I want to encourage you that we continue to ensure that there are preventable diseases that we can work together, as that your focus is more on capacity building, advocacy, creation of awareness, mobilizing people to know their responsibilities in their communities, working with the communities. You know, health training, all these doctors you are seeing here, they start from home. They start from you and me in our homes, in our villages. And that's why I'm happy that for a long projection and the mission of Mary Stops Uganda was to ensure they enter into the communities, because that's where everything originates from. Working together, we can end preventable deaths of women and children in Uganda. Women and children have a right to quality health care and to survival. Fundamental rights that are given to them is to ensure that everybody is alive, especially that you ensure for their good health. It is our responsibility as a government, it is our responsibility as all citizens. Working together as partners ensure a well-coordinated and integrated approach. We shall continue to make sure that our priority areas are to reduce maternal mortality, which we are aware that the most important direct cause of maternal mortality is hemorrhage and other effects that have been outlined, especially when the country representative reported that their focus is so much to ensure that all that are the causes of the maternal health and our child reproductive system gets to good quality, and together we can achieve what we are. We need to increase to the services. Uganda is scaling up training for health workers, provide PAC, including counseling. I've seen most of your components about counseling. So a store that has emphasized on advocacy and counseling, and every store I've seen, even those which are dealing with family planning, this is an effect that once we don't go into that area, and our clients, our people down there in the communities are not given hope, then our efforts will not be put to good use. So thank you so much, because your programs and activities are very much focused. These interventions, as have been outlined, need to be strengthened by all partners who can contribute towards the achievement of maternal and child health care for a good health system in our country. And I welcome all the efforts that are being focused to ensure that this one is achievable. Ministry of Health applauds the efforts of all partners present here, including our development partners, donors, civil society, everybody, the religious groups, all our communities, and everybody that is offering a service to reach out to our communities to ensure that we have a very good health system. Once you have a good health system, you have a good health population, and our economy will be health and very accelerated. So I wish to thank all of you, and I want to thank each and everybody here to encourage you that we work together and we ensure that we move and mobilize our populations to ensure that we don't face another wave that is soon coming in or that is unexpected. We don't know when this COVID-19 is ending and going away, but it won't go away unless we chase it away. It's not the one that is looking for us. We are the ones that are driving towards its course. So once we avoid where it is passing, we can all be secured and sure. I call upon all of you to join the Ministry of Health and the country and the President for that matter to ensure that we mobilize our population to get vaccinated. All our vaccines that the doctors will tell you are preventive and a preventing measure. All of us have been vaccinated before. We are here. Those who passed away. But then for us, we are here. So we should carry that message that vaccines are for prevention. And once we all prevent ourselves, the effects of those that are vaccinated is not the same of those that are not vaccinated. So that is it. But where you find somebody saying, I'm waiting for so and so who has been vaccinated to die first, we don't die now. For me, I've been vaccinated for the last, I think, 5 months. I'm still here. If I die, that means it's not a vaccine. And for those ones vaccinated are waiting for those not vaccinated to die. So you were vaccinated. Why do you wait for another one? Just tell the person, go and get vaccinated. Vaccines are available, and as we project, we think by the end of this year, up to early 2022, we want to have a population of at least covering 22 million vaccinated. So let's come together, and I want to ask and request the stops, our partners, good partners who reach out the communities to work together with the VHTs so that we ensure a healthy community. And I want to thank you for this day, having invited me, and for the purpose to showcase your journey. You see, if you start on a journey and you don't showcase where you started from, where you are going, nobody will know what you are doing there. As you have said, most people know and it stops. And I want to thank you because you have confidence from the public. I knew you. I trust in you before I came even the Minister of Health. I know people from my communities, the services, and everybody outside there, they do appreciate the services you are giving tirelessly and committed. So, but now here you are to say, Ugandans, everybody, this is our journey, this is where we have reached, this is where we came from, this is where we are going, and together when we join hands, we shall add value to our service system, we shall add value to service delivery in this country. With that note, I want once again to thank you, to wish Maristops Uganda a prosperous future, a good journey ahead, successive journey, and to accomplish your mission. I thank you so much for God and my country. You are going to excuse me if I can sneak in at another later time, but I need to go and open the ministry's review strategic plan this morning. But as I know I would want to be with you again, at least by lunchtime. If I miss the others' lunchtime, I may come again. Thank you so much.
Thank you so much, our minister. That was quite a powerful speech. We appreciate your confidence in Maristops. We appreciate your advice that you've given us. We appreciate your time that you've given us this morning, and we recognize that you have to be at the joint review meeting, but we really appreciate. Thank you so much for your time. We also want to thank the government representatives in the House for
prioritizing access to maternal health, despite the disruption that COVID has brought to the economy. As Marist Stops, we continue to commit to raise awareness about COVID within the communities that we work and to continue integrating it within our service delivery approaches. We want to introduce the Marist Stops board members that are in the house. Dr. Fred Sebisubi might have, okay, he's over there. Thank you so much for being with us today. Dr. Olive Setumbwe has gone out with the ministry, but we also appreciate her and also recognize her in the capacity of WHO. So now allow me to invite Makerere School of Public Health to give us a keynote address on the Performance Monitoring Action Plan. Specifically, they'll be making a case for why we need to continue investing in family planning and how we can adapt our services to ensure that we reach the most vulnerable communities. Dr. Simon Peter, you're welcome.
Good morning, ladies and gentlemen, all protocol observed. We are invited to make a keynote presentation, and we hope it can be moving enough to cover one of the areas that the director mentioned for the next strategy, and that is family planning. So our presentation is titled "A Case for Continued Investment in Family Planning." And this is evidence from the PMA surveys. The PMA surveys, PMA means is Performance Monitoring for Action. And these are surveys that are carried out by the School of Public Health at Makerere University with support from partners Johns Hopkins, Japaigo, the Uganda Bureau of Statistics that does the sampling, and also supported, of course, by the Minister of Health, provides us the permission to go to the facilities and the districts where we go to. So that's what we are going to use to make this presentation. But before I start, I wanted to start with a story focusing on quality of family planning services. Our phone numbers, mine and Professor Makumbi, who is my senior colleague, happen to be on consent forms for the surveys that we conduct. So these consent forms, of course, are left with women and men in the households when we go to collect the survey and at the service delivery points where the survey is conducted. But those phone numbers, including the phone number of the Research and Ethics Committee, are basically for participants to call in case they have more questions about the survey, specifically about the survey, or their rights as participants. But many of the phone calls we have, and right now we've just completed data collection for the 2021 survey, which is not what we are presenting here, which we shall invite you soon. But most of the calls we get are actually calls from women seeking support for family planning. And that support is always, I think 95% of the time, about side effects. And I am not a medical doctor, Professor Makumbi is not a medical doctor, so we always have a team to recommend to the School of Public Health for them to be supported and then directed to the nearby facility, and when they reach there, they call so that somebody at the school talks to the facility person. Now, you can't do that everywhere. But also, as later we'll see in this address, you'll notice that the quality of family planning services is still a challenge. And although in research, we always talk about research problems, today I want to talk about statement of opportunity. Although there are issues, really challenges, but there are a lot of opportunities, I think, as MSUG and all the partners and ministry that we can take on to be able to advance the best services. About barely 2 weeks ago, I got a call from a woman in Mitoma district, and she had an IUD inserted through outreach. And this woman called was speaking in Nyankole, I figured out, I tried to gamble, I was at the school, I called somebody, it's called Musinguzi, to listen in so that we, be able to speak the language. And then the challenge is that she had an IUD inserted and she was going back to the facility for support. She had visibly signs of STIs, and, but she could not get support from the facility because the facility person told her to wait for the outreach team that inserted the IUD. Now, this is the kind of, it's maybe an isolated incident, but I want to give this example because it's a real call, a real woman out there in the field struggling. And so I think it was Dr. Justin Bukenya that we worked with to be able to direct the woman back to the facility and talk to the facility person ourselves to be able to get this support. So I think this speaks about the quality of services that we are providing, but also the information that they have at the time they seek the services. So let me go into the presentation. Next slide. This is just the layout of the presentation. I'll take you through a bit of the family planning use, and then also take you through the quality that I'm focusing on, and then reproductive health events, and then public sector service delivery. I know that the strategy, Dr. Carroll, you presented, you want to focus a lot on private sector strengthening, but I think you should not forget strengthening the public sector as well, because although we presented that the first contact is the private sector, but I think for family planning, about 58% are still seeking from the public sector. So it's still the preferred choice it means. So we need to strengthen it as well. Next slide. I presented this, so you can just go to the next slide. Okay, so this the next is about basically family planning use and focus on the method mix and a bit about the demand and what demand we're actually satisfying. Next. Okay, so this probably some people have seen it. This is from the three last surveys, 2017, 2018, 2020. And this is current use of family planning at the time of those surveys. So this we call the contraceptive prevalence rate, and among married women 15 to 49 years. So what you see is that in the last survey, which was conducted last year, September, October 2020, our contraceptive prevalence rate was at 44.8% among married women. And of that, 37% was for modern methods and 7.6% for traditional methods. But I want you to focus on the traditional methods and how they are rising. The rate of rising there is about 38% change in just 1 year, between 2018 and 2020, just 2 years. While for modern methods, the change is only 2.4%. So it speaks to where, either some people are running away from the quality, I don't know, and going to, areas that may not be as effective. Or these are new users, new people coming on board, and they are starting from the lower end. So it may be an opportunity anyway, that we need probably to move more women as they enroll into the traditional methods, to move them to more effective methods. And I think as MSUG and partners, this is an area to focus on because you want, I think, all the women to be using methods that are effective, that can support them, other than methods that can, lead them into trouble at some point. So that rate of change, I think we want the modern methods rate of change to be commensurate with the traditional methods, if at all we, speak at par. All have the modern methods really, the one rising much faster than the traditional methods. Next slide. So I want also to present this by region, just breaking it down. And just a disclaimer that the PMA surveys are not necessarily powered for all the 15 sub-regions. So this is descriptive. So the confidence intervals, the point estimates may be running around a little bit, so we need to focus on confidence intervals. And when we do the DHS, maybe presented next year, you may see maybe Elgon may be at 60% or something, but we're talking about confidence intervals here. But if you look at one of the for MSI, I think MSUG, you want to focus on leave no one behind, and you want to focus on hard to reach areas. I had the minister asking at one of the stalls if you've been to Zimbabwe and which areas you've been to in Zimbabwe. And I think those are the hard to reach areas. Look at Karamoja, single digit MCPR versus a region at 53%. So in some cases, you have regions like Ankole and Elgon Because if you look at the confidence interval for Ankole is, has hit 50%. So these are two regions that have hit our target that we set for the country for 2020. And then you have a region at 7.4. So when we say leave no one behind, we are talking about an entire region left behind, not just a few individuals, an entire region, ladies and gentlemen, left behind. And also others, West Nile, Acholi. Basically, I think we have an equity challenge in the northern part of the country, and we need to focus where the issues are. I think it doesn't surprise you that some districts like Amudat in 2014 had a TFR, total fertility rate of 9 children per woman, and doesn't surprise you with, a single-digit MCPR, okay? So, and if you also look at, I also highlighted Kampala here, because Kampala, by UBOS description, is 100% urban. And so sometimes you may think urban areas maybe are doing, better, but Kampala should be the best performing region. Therefore, if it is purely urban, it's 100% urban, but Ankole, Elgon performing better than Kampala. So it means even within Kampala, they are very poor people. They are people who are vulnerable, and so when we focus on just a region alone, there are people who are masked in there. If you go to Ankole, we did a hotspot mapping a few years ago, and we have districts like Rubirizi that are struggling, that are masked in districts like Mbarara. So when you focus on a region and you think that region is okay, let's go to a region which is struggling, there are districts within the regions that are struggling. I think we need context-specific interventions as MSUG, as partners, to be able to ensure that is lifted to the area that we want them to be. Next slide. So this is a demand, a total demand that we have for family planning and demand satisfied. And the row that, unfortunately I have no pointer, but the row that has total demand, third row, which you see from 64.9 in 2015 to 68.8, you see that we are not rising enough in terms of total demand. That total demand should be much higher than that. But also if it's much higher than that, row 2, which is all method CPR, should be up there. But you see that there is a large contribution of total demand is actually animate need, which is row 1, okay, 23.8. All that, because total demand is a combination of women who have an animate need for family planning, meaning they're not using a method, but they don't want to get pregnant anytime soon or not at all, plus those who are using a method. That gives you the total demand. Now, all that demand in the ideal world should be satisfied, but we only satisfying by modern methods. Modern methods are only satisfying 54% of that demand. And of course, we, focusing on lax and all that, I think that's where we need to go and make sure that that demand, even that little that we have, can we meet 90% of that? If we only focus on meeting 90% of existing demand, we'll be doing well. But I want also to still drum up I think, for MSUG, the demand generation. I think we need to demand, to generate more and more demand. How do we generate more and more demand? By ensuring that the desires for family planning, for children, are a little bit, the appetite, a little bit less. When you lower the appetite for children, you're going to increase the demand for family planning. Because many of the women, like you'll see in one of the regions I'll present, about 37% of the women are saying they want to get pregnant within the next 2 years. All are pregnant by choice currently. So if you have such a huge number, Dr. Jotham, was launching the population policy last week. If you have such a huge number, you're not going to deliver this country to achieve the demographic dividend, because you have so many people that are still willing to have so many children by choice, by the way. Although our mission is children by choice, not by chance, but I think that choice should be a very informed choice, not just saying I want to have 5, 7 children, but it's not an informed choice. So if we drum up that, then that total demand, that what we meet should be, and if we create more demand, then we have another market to be able to satisfy. Next slide. So this is what I'm breaking down, the same graph. I'm breaking down by region. I focused on 2 regions, a Western region in general as a block, and then the next slide will be on the Buganda region. Now look at the Western region, Ankole. The total demand may not be as high, by the way, Ankole, 66.8. But interestingly, 7.6% of the demand in Ankole is met by modern methods. So you may have less demand, but it's met by modern methods. But if you go to, other regions like Bunyoro, you see that the total demand is much lower anyway, and Toro, total demand is much lower. Now, this is, if you ask everyone in Western Uganda to be at the same page, you're going to, miss out on, some of the regions. But also, in Bunyoro, I want to focus on that Bunyoro. We've sliced this pie to leave the white area. That white area is actually, those are women who have desires that they want to have a child within the next 2 years, or they are currently pregnant by choice, according to what they report in the survey. Now you see that in Bunyoro, 7% of the women are currently pregnant by choice, or they want to get pregnant in the next 2 years. Therefore, they cannot form our total demand because they have no unmet need. If you ask me in the survey, do you want to get pregnant next 2 years? And then I tell you I'm not using a method, of course, because you want to get pregnant within the next 2 years. So it is okay not to use a method. So we cannot quantify you as unmet need. We only qualify you as unmet need if you say you don't want to have a child within the next 2 years. So you should be doing something to avoid getting pregnant. But if you have 37% still wanting to get pregnant, I think our SBC team needs to focus on that. How do we lower that appetite that I was talking about? Next slide. So this is for Buganda region, and I brought out Kampala intentionally here because we said it's purely urban. But look at the method share. Kampala is 68% in terms of demand for methods. South Buganda, where the minister's district, Zimbabwe, is 71%. So South Buganda has a higher demand, total demand, than Kampala. But the challenge is, of course, a lot of it is under unmet need, okay? And Kampala's demand is 68%, but only 62% of that is met by modern methods. So much less than, for example, Ankole at 2%. So you see that. But also there's something you need to focus on here. We're talking about the rise in traditional methods. And we may think this is rural areas. Look at Kampala. Kampala, the traditional method use is at 13.6%. One of the regions with the highest use of traditional methods. And this is also true when we do analysis by wealth quintile. We see that actually there are way more women in the highest wealth quintile who are going for traditional methods. So we need to understand what is it that is there. Are these women who are able to notice the quality of services and demand for more at the facilities, and therefore are able to go into self-care, or is it just a demand for self-care, the buzz where we are going? So how do we focus on bringing self-care to modern methods and not limit it to traditional methods? And I think this is an area as well, MSUG, that you could focus on for your 2030 strategy. Next slide. And now these are trends in the method mix. The method mix is very important. In the ideal world, I think the method mix should be equal. Every method should have the same proportion. In the ideal world, it's not real, but that's the ideal world. Now, these are trends. You can just focus on the last bar, the last survey, and you can see that we have had a huge rise in implants. Implants have more than doubled from about 13% here in June to 31% in 2020. And I think that's a very well-deserved clap because that's where we want the country to go. But I had a question. Why is it that IUDs are not rising at the same rate? IUDs were at about, 3%, now 5%, no big change. These are all long-acting reversible methods that we are promoting together. I don't know if we are intentionally promoting implants, or this is the choice of the women that they are choosing implants by choice, and not us driving implants and not IUDs. But I think we need to make sure that the long-acting reversible methods are taken up more because we know all that they are much more effective than the short-term methods. So that is something probably we want to go to. And also, Dr. Kari, you mentioned self-care. I think you can see that the Sayana Press or DMPA-SC is also rising. It is eating a lot into the IM. That is at 19% now. At 18% versus 19%. So almost equal at the same with DMPA. But you see that DMPA over time has been coming down, and that is because of the rise in implants. So we want to go there. It's a good direction. It's a good opportunity. Let's keep driving the country, I think, to that direction, and I think we shall do well. Next slide. So now focusing on quality of the services. Next. Yeah, this, and maybe just one more arrow. So, no, just the other one. Okay, I thought it was animated, it's not. So, this is what we call the Method Information Index Plus. We have four questions that we ask women at the household level. So when we come to the household level and we find that you're using a method, for those who are currently using a method, we don't care when you obtained it. If you got it in January, or yesterday, or last week, or last year, we ask you at the time of getting it, were you told about side effects? Were you told about what to do about the side effects? Were you told about the possibility of switching? And also were you told about the availability of other methods? So that you make an informed choice of which method to take, and you know the potential challenges with that method, but you also know the beautiful things about that method. That is the comprehensive information that we want. And this speaks about the quality. And I think this leads to the lady that I talked about in Mutema who called in. You're not told about side effects. So if something pops up, maybe it was something that would be manageable, but because you're so scared, you're looking for support from elsewhere. And I don't think you're going to go back to the facility where you did not get that support in the beginning. So you're likely to be looking around elsewhere. And I think then many people may land into the wrong hands, told to do certain things which are wrong, and then we get into trouble. So we see that, of course, there is no big difference between the urban and the rural. Overall, only 42% of the women who are currently using a method were told about all this package. And we also we also see that there is a disproportionate share about this for the adolescents. Dr. Dina, I think this is really your concern. 15 to 19 compared to the 25 to 49. You see all the other confidence intervals overlap except that one. It seems that at the facilities, the adolescents are not getting a raw deal. Now, those few, and there's a channel here on adolescents, those few adolescents that pop up, if we do not satisfy them, one of the MSI, I think, strategies that you have is you want to focus on peer-to-peer approach, and you also want to look at, refer a friend. I saw cards there. How do you expect an adolescent that is not getting full information to offer peer-to-peer support? How do you expect them to refer a friend if they're not getting the quality of services? So these few that pop up, we need to make sure that we deal with them extremely well, that when they go back, they have a story to tell. And now, you may not be walking away with the method, as you see in the next slide. You may be just walking away with information, but you need to be told about all this detail. And you see that it's a very big challenge. Only 28% of adolescents are told, have all this method information index. So I think your strategy, Director, about focusing on adolescents is really well guided. Evidence is there in the data, and we know the country is extremely young. We need to make sure that we don't have unintended pregnancies that we shall see later in the slides. Next slide. So, and now, the previous slide was focusing on women at the household level. So last year what we did was we did what we call client exit interview. For the facilities that serve the enumeration areas where PMA goes, we also conducted exit interviews with women who are leaving family planning clinics, or those who have received a family planning service. This doesn't have to be a method, it can be information only. So what we see is that the first question we ask before biasing them is whether they are satisfied with the services they have received. Amazing, 95% of our women are extremely happy about the services. But before you clap, when we ask further, during today's visit, did the provider tell you about the advantages and disadvantages of family planning, of the method you took? Only 54% said that they were told. Now, there is a clear mismatch. 95% of the women are extremely happy with the services, and yet they're actually getting a raw deal. So what is the problem? And I think you had something about empowerment. We need to make sure the clients know what to expect. Because if you don't know what to expect, whatever they give, you're going to be happy with it. Because you don't know anything else. If you came to my home, what I usually serve is tea and binyebwa, ground nuts. And if you take black tea and ground nuts, and at home you've not been taking anything, and they ask, are you happy? Yes. But if you're coming from a land of milk, and you get black tea and vinyewa, maybe you're not going to be happy. But also if you know that the visitors are served milk, but they served black tea, you're going to say, I am not happy. But now I think we have clients who don't know what to expect. I think we have extreme respect for the health worker, which is very good, but then we need to make sure that the clients actually know that the package to receive. I don't know if that falls under the SBC or whatever we need to do to make sure the clients are empowered, so that they don't just say we are happy. When we ask more questions, we notice that actually they're not getting what they're supposed to be getting. But also this means that this measure is not a good measure when we ask about satisfaction. We need to ask about a series of questions that include what they should be getting, other than just asking a direct question whether you're happy or not. Okay, next slide. And maybe just focus on the other one as well. Is those ones are really, that is fresh information because you're just exiting. There's no recall bias. You are interviewed on that same day. Okay, so now I think when you see the last two slides, with the quality of services that are provided, they are good. We are trying, I think, as a country. But then I think it should not surprise us, therefore, that 57% of the episodes that were started in the last 2 years were discontinued by 12 months, in the first 12 months. And of those, only 5% were discontinued because women intentionally wanted to become pregnant. 52% were discontinued for other reasons. So it means you have 52% of people who are falling into a risk that they don't want to go into. But because when we break it down further, we notice that side effects is a huge problem. And then we go back to side effects and we notice that only 54% are told about side effects management. So if you're not told, you're going to drop out. But I think if you're told that this method will cause you some nausea, this method will give you this, then when it happens, yes, you may not be happy, but you're not surprised because they told you it's a possible effect. And therefore, you're likely to hang on more. You're likely to convince your colleague to hang on more. But if you are not told, you're going to drop out. Because I'm experiencing this ABCD, so you're not going to have the support. But also, where do you go when you get into trouble where you did not get the right service at the beginning? So we need to make sure that, Dr. Kara, I think public sector service, strengthening should not be left out, not just the private sector, because we see family planning services are mostly from the public sector. So we need to strengthen that area. I don't know if it's more health workers, the ministry, or more training, if people are overwhelmed. It's so many things that we need to focus on and see how to improve that. Next slide. And I think this is just breaking down discontinuation rates, but also I wanted to speak about this because we saw that the country is trending towards implants more, and I'm happy to report, of course, that implants have the lower discontinuation rates, for example, than injectables. So the red is those who are discontinued for side effects. And you can see that for injectables, a lot of women are discontinuing for side effects, while for implants, they are slightly fewer. But still, if you have about 19% of episodes discontinued for an implant in just 12 months, I think Dr. Carr, at one session you mentioned about contraceptive wastage. That's a term I had never heard about well. But this is contraceptive wastage. An implant is supposed to last how many years? 3, 5, and somebody is taking it out after 3 months. That is wastage. So they should have been on a pill anyway. Okay? So if they are taking it out for side effects, then we need to make sure that we tell them what to expect when they get that implant, because we had thought that we have covered that woman for a longer period of time, a couple years of protection. But then they are removing it actually after some time. Next slide. This is now, I think, about empowerment as well, vulnerabilities, because we see that we had a male involvement, I think, mentioned at one of the booths. We need to make sure that our men are really, really involved. We don't need to miss that out. I think it's the SBC. We see that the chart on the left of the screen is for those who are current users, and the other one is for non-users. So this covers all women in general. And what we see is that 48% of the current users, the decision to use contraception was a joint decision, which is okay. But there is a 14% there, which was mainly by the partner. It is the man who decides whether he should use family planning or not. That is dangerous, okay, rights. But also what is more dangerous is that 8% of those who are not using, the decision not to use was taken by their partner. So when you combine all of them, you see that 13% of non-users have a decision that is taken by someone else. Either their partner, 5% maybe, I don't know, mother-in-law or someone else. So it is really very dangerous that 13% of the women don't have take charge of their lives. But also the others, for example, 70% of those who are not using this, was their own, that's okay. But it could be that they are their own, but it's influenced a little bit in the background. This is the final decision that they're taking. Next slide. So now let's focus on reproductive events. I'm about to get to the end. Next. Where should MSUG go? This is, I think, now about the children by choice, not by chance. And we are getting into the uncharted territory of unintended pregnancies. We have our young people 18 to 24. This excludes, of course, 15 to 17, because when we're analyzing this data, there's something called censoring. So you cannot analyze people who have not had a chance to experience the event. So this is 18 to 24, and our age is 18. So you should have had at least that age 18 to qualify. So, but we see that 56% of the young people have reported to have had sex before age 18. But only 19% reported to have used contraceptives. These are not married, many of them, some of them. And so then they're not using contraceptives. Only 19% used a method of contraception at the time. So we have sexually active young people, although sometimes we deny, but then there is no use of contraception. So next slide. So it shouldn't surprise us, therefore, that we'll have something like this. Okay, this is Dr. Jotham, your slide, but presented differently. We have the urban women here, and this is the median age at reproductive events. And you notice that in the urban areas, median age at first sex is about 17.7 years, and first contraceptive use only happens at 22 years, median. And you notice there is a gap of 4.7 years of waiting. You've had sex, you probably continue to have sex, because when you try again, and then you're not doing anything to avoid getting pregnant. And it doesn't surprise you, therefore, by that time, you've already had, a child or 1.5 children by that time, on average. So, but when you go to the villages, rural areas, it's much worse. Sex starts early. Sometimes we think exposure is more in the urban, it's actually more in the rural. 16.8 years, first sex on average, median, and then first contraceptive use happens about the same time, 22.5 years. And by that time, those are 5.7 years, and by that time, they have had about 2 children. So you can see that the problem is more compounded in the rural areas. So vulnerabilities, I think that's where to focus as well, a lot more. And when you see the events in the middle there is first birth and first marriage. I think you see there is a huge difference between the urban and the rural. There is the urban first birth is at 21 years, the rural first birth is at 20, and first marriage for the urban is 21.3 years, comes after first birth. But in the rural, first marriage, people go into marriage, then they go into birth, but very young. So because first marriage happens very young, it doesn't surprise you therefore that they have children already by the time they start to use contraception at 22 years. Next slide. Now, this is what I said with all those issues we've had, with all the quality of family planning services, with all those ages at reproductive events, the product is here. The last birth unintended, 43% of the women reported that their birth was not intended. The last birth or the current pregnancy they had was not intended. There is no way we are going to drive a country to, to the whatever world we are getting into when half of the births are unintended. People just, these are children by chance, right? But when you go to the adolescents, in the villages, the purple are the rural areas and the green is the urban. In the rural areas, 69% basically have a child that they don't want to have. And of course, these are very young people, but look at how bad it is there. But even for the older women, it's still very bad that people are still experiencing births that they don't want to have, okay? So 2 in 5 have had an unintended pregnancy, and that, I think, speaks to where, because they have dropped out from contraception, the discontinuations we saw, they result into this. If 52% are discontinuing, of course, episodes are discontinued, of course it's going to result into this because they are still having sex. So we need to focus on packaging all this together and see how to tease out which areas to focus on. Next slide. Okay, this one I picked it from the 2018 survey because we didn't have time to analyze for the 2020. But it is the same, but this is now by wealth quintile. The lighter is Q1, quintile 1 up to quintile 5, the dark one. So you see that 56% of the last pregnancies, current pregnancies, last birth for the women in the lowest wealth quintile were unintended. 56% of the last pregnancies or births for the women in the lowest wealth quintile in the poorest households was unintended. Vulnerabilities, we need to focus on those poor communities and make sure that we actually deliver them to children by choice. But it's also not good that even the top wealth quintile, 30%, near a third of the births are unintended in the top cream of the country. So if the top 20% of the country have 30% of their births unintended, what do you expect downwards? So it is a big problem. I think we have a lot of work to do. These are challenges, but also the opportunities. I think a lot of opportunities to increase contraceptive use are really presented. Next slide. Okay, now this is about the public sector. I think about two more to go. This is reasons. I skipped the slide for stockouts because I think we've seen it before, but I wanted to focus on what are the reasons why there are stockouts in the facilities. And that is the overall that I've circled here. And you see that, you know, half of the reported reasons for stockouts are supply-related, but also a third are actually demand-related. We have facilities that are struggling to quantify, okay? Didn't order the right quantity, green, 4.5, okay? There are those that ordered but didn't receive. Challenges here, Dr. Jotham. And then there are those that had unexpected increases in demand. So I think we need to make sure that we equip our providers to be able to make quantifications right and also kind of project the demand. Because I don't think you have a surge in the community and then suddenly unexpected increase in demand for methods. Because we've seen that our MCPR is not rising so fast. So if it was rising so fast that we're doing a lot of work in terms of drumming the demand and therefore they go to the facilities and there are no services because there was unexpected increase, that would be justified. But this is, I think, an issue with ordering the right quantity. So capacity strengthening for the public sector to be able to do this very well, I think, is needed. I think the picture is similar maybe in the private sector as well, but I'm presenting this for the public sector. Next slide. And this is also now facility readiness. We've seen that the country is getting into long-acting reversible methods. Now, we have a huge window of opportunity. So why don't we make sure that our facilities are ready to provide those methods that are very effective and we see that couples and women are going for them. So we see that only 57% of the facilities that are providing, because these are facilities that are providing IUDs, they told us they're supposed to provide by level and all that. Only 57% actually had a trained provider and instruments or supplies for insertion and removal. Only 57%. It means therefore that women would walk there and then the IUDs cannot be inserted. But maybe that woman has had that one opportunity to run away from a violent relationship, to run and go for the facility because the man has gone somewhere. Maybe that's the only chance they have to interface with the facility. And they want to take a method for 5 years. And they miss the chance, they go back home unintended pregnancies. So we need to make sure that the facilities are really, really, really equipped. And for me, I don't know what's up, but I think we need to make sure that they even go further to the lower levels, if possible. Because we know that that is where the niche is. That's where, when we get many women going into lakhs, we are going to have a much better output. And then, of course, for the implants, the picture is slightly better. 76% of the facilities were ready to provide because they had a trained provider and instruments to insert. But now imagine if facilities don't have these services to insert and remove, and then you've inserted an IUD or an implant through outreach, then the next day the woman wants to go to the nearby facility for removal or after 1 year, and they cannot. They have to wait for the outreach team to come. So those are real challenges, I think, that we need to tackle. And therefore, I think I still say public sector strengthening, but maybe also the private sector strengthening is the way to go because this is sustainable anyway. As you talked about financing, this is free, so it's sustainable, I think. So we need to get there. Next slide. So I'm presenting now, these are just last 3 slides, as what are the opportunities for MSUG? and the general partners, but mainly today for MSUG. So we've seen that under family planning use and demand, demand has stagnated, in the last 2 years, and the demand satisfied by modern methods especially has actually stagnated in the last 2 years. So we have an opportunity there to, take that up to satisfy the demand that is already generated by modern methods. And also, we have a rising share of lacks, as we said, in the method mix. So let's grab that opportunity and make sure that facilities are ready to provide the long-acting reversible contraceptives, and then we cover many more women. And of course, we've seen regional variations in MCPR. I called them regional variations, but they're really regional imbalances. There are areas that are really struggling, and there are areas that are doing very well. Can we learn from the areas doing very well and see what they have done? Maybe it is a mindset change. Maybe it's, the outreach is there. I don't know, but we need to, I think, to kind of pick lessons from one region, take them to another region. How do we support areas like Karamoja, to be able to get out from the single-digit MCPR? Next. This is the second last. So now, what about adolescents and young people? We've seen, of course, that over half of the young people, 18 to 24, had first sex before age 18, but only 2 in 5 actually used a method of contraception by that age. So opportunity to make sure that those who are sexually active, we are drumming as much as possible. We want the adolescents to not to have sex. But when they do, what do? We cannot just throw them away. We need to make sure that we support them. There's a wide gap between first sex and first contraceptive use. And so we need to make sure that when they're initiated into sex, either we find ways of stopping them to only stop at the first incidence, or make sure that when they do again, they go in with protection, with ways that cannot help them not to get pregnant, but also, of course, not forgetting HIV as well. So maybe the methods that are more suitable for such group. And then we have persistent unintended pregnancies, mainly in the adolescents and in the rural areas of this country, and we need to make sure that we tackle that. But we've seen that even among the rich, it is still a problem. So we need to make sure that everyone is on board and using an effective method to stop that. Last slide. So what about the public service quality? We've seen that FP counseling remains suboptimal within the public sector, but also worse for adolescents, because it seems there's something about the attitudes and all that the adolescents don't get what they need to get. Or maybe the adolescents, when they get there, they're running to, because of the stigma that is associated. And then side effects and health-related concerns are key determinants of discontinuation. We need to make sure that we tackle them by improving the quality of services we provide, by making sure the counseling is well done, to ensure that these women do not discontinue when they experience those side effects, because they have already been made aware about them. And lastly, we see that there is suboptimal facility readiness to offer long-acting reversible contraceptives. And that is an area that we've seen that we are running towards implants. We need to make sure we keep that trend. We don't want it to come down, but also especially running into those who are non-users to make sure they come on board with facilities being ready to provide those methods. Ladies and gentlemen, I submit.
Again, a big applause to Simon. I think one thing we've learned over time, without data, we'll continue to hit in the dark. And with such data, it guides implementation, it guides decisions. So Simon, thanks very much. But also let's make this data available in many ways. Quite a number of implementing partners operate with minimal data or no data. I think, again, I'm going to request all the authorities that if this data is available, let's disseminate it as widely as possible, not only to us who are implementing and providing services, but there are key decision partners out there. If you go to the district level and you realize that the bigger decision makers are the politicians, how many of those are having this kind of data? So you'll find the data is at the ministry, is with Maristops, is with other implementing partners, But there are those key decision makers, the religious leaders, the cultural leaders. If we have this information at all levels, I think it will help us a lot in terms of pulling the demand into play. Without taking a lot of time, I'm going to welcome our members of parliament in the House. They can just wave at us. Welcome. Welcome. And then our dignitaries from the embassies in the House, you're welcome. The next phase we are going for is break tea. But before we go for break tea, we, because I'm looking at my watch, and when we look at our program, we are supposed to have a discussion. But I'm thinking, and I'm going to consult, if we can go for break tea, then we do the discussion. And in the interest of time, we can have a working tea. So people serve, and then we come back here, and we give ourselves 20 minutes to be able to continue and finish on time. But before we break off, members as a take-home, in the layman's language, we don't want to say that every person in this room is technical in sexual reproductive health. But in a layman's language, there are things I've picked up. And these are questions that are coming in my mind, and I'm teasing all of you to ask yourself these questions, and we start to look for answers. One, Simon has showed us that the traditional methods are going up. What is the magic? What are those guys doing that we're not doing? And we've seen modern contraception, the increase or the growth rates are low. What can we do, or what can we borrow from those guys that are promoting the traditional methods? And I've seen them on TV a lot. I hear on them every time I'm in the car. And unfortunately, when they are giving the information, they talk negative about the modern methods, okay? There is one here on Gaza Road when I'm turning to my home. They have a very big megaphone up in the space at the marketplace. Every time they're talking negative about modern contraceptives. So what can we do to make sure we sort those, we learn from them, and then we incorporate their ideas into the modern contraception? I'm not going to repeat everything Simon said, but the other thing is about the young people. If you look at the population of Uganda, we are highly dominated by the young people. And if we do not concentrate to understand the young people, to provide services that suit their interests, to have methodologies of handling them to their satisfaction, then we are going to actually derail our efforts. And so those are the two things I learned from Simon's presentation. The increase in traditional methods and the focus on the young people. I think if we hit that, then the rest can follow. In the interest of time, can we go for breakfast now? Then working tea. So we can serve from behind. We give ourselves 20 minutes. It's now 11:30. So 10 minutes to midday, we come back here, and then we continue. Thanks very much. Tea is served outside. As you get out of the entrance, that's where tea is being served.
Ladies and gentlemen, as we go for tea, I was just saying, William forgot to introduce my bosses, but he said he did. I want to take this opportunity to show you some of the members of the Marriage Stops board. Dr. Olive Sentumbwe and Dr. Fred Sebisubi. Those are two of our 9 directors. Thank you for making the time.
check, 1, 2. Check 1, 2. Check 1, 2. Check 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Check.
Ladies and gentlemen, can we come back to our seats and we go into our next sessions? We want to be cautious about the time. I'm going to request Maristop staff, please help me mobilize people outside to come back, and we begin in the next 1 minute. Fred Musajamukulu, can you help mobilize the people out to come back, and then we can start? In our next session, we are going to have a panel of experts chaired by Dr. Moses Muonge, and we are going to have a discussion. To begin with, we are going to have a discussion on what Dr. Simon of Makerere School of Public Health has presented to us today morning. Let's share some information on the presentation of Simon. What can we do to actually take advantage of the opportunities? I will not call them the gaps, I will call them the opportunities he has showed us. And then thereafter, again, the panel of experts will be able to answer some pertinent key areas in sexual reproductive health. So, Dr. Moses, I'm going to invite you to take over this session as the chair, and you will invite the panel members. In assessing and providing guidance to us, the implementers, MOH, on what it is. Dr. Mwonga and the team have done a lot of steps. They've done a lot of trainings on the key interventional areas in sexual reproductive health. So Dr. Mwonge, welcome, and he's going to be our chair for the next session.
Thank you so much, William. And it's my privilege to be here today. Protocol observed. This session is going to help us get a deeper understanding of where we are as of now as regards sexual and reproductive health. And I would like to say that the main presentation by Simon was a good start for an introduction to this session. One thing I would like to also add on Simon's presentation is that the modern contraceptive prevalence rate within the East African region stands at an average of 39 for married women. And Kenya is at 58%, Rwanda is at 53%, and Uganda is at 39%, leading Tanzania, which is at 4%, for 34%. So that tells us that our neighbors, some of them are doing something good, that maybe we could learn from. We are all in the same region. We share most of the characteristics, but they've moved 50, Rwanda and Uganda and Kenya. The other issue I would like to say is that when you walk on Kampala streets, and Simon hinted on this, and you see 10 pregnant women walking past, 4 of them are pregnant not because they wanted to be pregnant, not by choice. But also, when again walk on the street and you see 5 women walking around and they are pregnant, 2 of them didn't want the pregnancy at that time. They wanted it later or didn't want it at all. I want you to take that. You are pregnant for 9 months for something you didn't want. So I would like to invite now my panelists. And by the way, I think it's once in a lifetime that I'm able to have Dr. Jotham as my panelist. Dr. Jotham is my mentor and is the Director General of National Population Council. Dr. Jotham, you're welcome. Yes, please, you can take a seat here. Dr. Olentumbwe. Yes. Joan, you're welcome. Joan Atuhire. Yes. The future of Uganda. And then Charles Owekumero. He's the chair, Sexual Reproductive Health Alliance. Where is Charles? Please come. Hey, the chairs are done. Oh, there's another chair there. Thank you. So members of the panel, we've seen the presentation about the state of Uganda family planning program. I would like us individually to reflect on that presentation. What do you pick out of that presentation? What do you think needs to be done at a high level? I'll start with my immediate, I'll start with Dr. Jotham Musinguzi to give us a highlight of what he picked from that presentation.
Thank you. Thank you, Moses. And is Simon still in the audience? Because I want to be sure what I say that either he listens or he doesn't listen. But it looks like he has gone. So first I want to really, is he there? Simon, I wanted to make sure I congratulate you on a very excellent presentation, of course. And it is a presentation that I think our honorable members of parliament who appropriate the budget for the Minister of Health, and I see the Director of Clinical Services, Dr. Charles Soraro, is here, and other people should listen in too, because it has a lot of information, a lot of it very practical and actionable. And I think it also tells us, and you kept talking about it, that there is a cost for inaction. And I think that's an important message. But I'll only pick two things I want to talk about. I am an optimistic person, so I just want to pick out the positive ones. One is that our contraceptive prevalence rate in the country is going up, slowly, but is going up, no doubt. Of course, we have to explain why some of our people who are both wealthy and educated are going for traditional methods, and I think we can, those of us who are here, who have research minds, I think we can start talking about what are the reasons for that. And some of them may be subtle, but there are reasons why that may be the situation. The other one I want to pick out is that we welcome the fact that the country is witnessing a steady rise of the LACs, the long-acting reversible contraceptives, in the form of especially the implant, and but not so much of the IUDs, but hopefully that should also go up. These are things that we can act on clearly, especially we welcome the LACs, especially implants, if they can increase. It is a reliable method of family planning. It doesn't have actually very many side effects. Once you have put it there, it is passive. You don't have to be bothered about it. Even your spouse may not even realize it is there. So, and we worked very hard on making sure this is on the table. What I lament about is the fact that it is not widely used, even in our rural areas where our women still are. So this is something that, as partners, Minister of Health, Dr. Charles Soraro, and our friends, Maristopes, and the other partners as well. I think in the audience there are donors there. I have talked about members of parliament, but there are also donors. This is an area that we can go into and quickly go up in a very practical way, and I think the resources are there. But it requires that we build capacities for, of course, human resources, but also get them trained and they have the equipment, and this is something that we can move on. So I want to stop there at this point in time.
Thank you, Dr. Jotham. Dr. Olive Sentungwe, what's your synthesis of that presentation?
Thank you, Chair. And thank you very much, Simon, for the presentation. One thing you mentioned is that 58% of clients are actually in the public sector. Indeed, that's where most of the population is, especially in the rural settings. But in the urban, and really that's where I want to congratulate Maristopes for trying now to develop the private sector for family planning. A number of women are actually accessing several private sector institutions now. In fact, they deliver there. But many will tell you that they never received the word on family planning. I think that's inconsistency and very unfortunate. Maybe the use would have been higher, because now they have to turn backwards to the private sector to receive FP services. So I really hope that going forward, private sector engagement for family planning is going to be a much stronger area of work for both Maristopes and, of course, the Ministry of Health, so that women don't have to get to deliver in a private sector and then have to move to another unit. That one is an important area of work going forward for all of us, and thank you for really showing that that area needs some work. Also, in your presentation, you showed definitely, for instance, that Bunyoro has a high unmet need of 27.7, but Karamoja use is only 7.4. But what is their unmet need? Since we even want Karamoja to learn from Mbarara, what are their major differences? Because I think we need to go into that detail. Actually, there is no unmet need in Karamoja. Even if they are at 7.4 use, they have no unmet need. That's where they want to be. So what is it that we now need to do to ensure that the society there has some change of what? Attitude, behavior, socialization. Because I think their socialization, their needs and demand is quite different from Mbarara. And so we need to go deeper to see what is it that we can do. I think we also saw 59 sexually active, but only 19% of adolescents using contraceptives, making it a group which is, I think actually they are the most sexually active because they are still young and they have a lot of exploration to do, but worst in doing what? Using contraceptives. But yet they don't want to get pregnant, I think. So in that area also, we still have a lot of work to understand why are our young people, adolescents, young people still where they are. Lowest use, but highest in terms of being sexually active, as expected. So what is this low deal around adolescents? Historically, how has it come about? And what are the different sectors trying to do to address it? Because I think this is going to be a sort of multi-sectoral approach to address sexuality issues, to address, then if you decide to be sexually active, how do we prevent the unplanned pregnancies and HIV together? And so I think there also, thank you for bringing up that, and thank you, Maristops, for ensuring that probably this is where we are going to focus, all of us going forward. COVID-19 has brought out this, that even when we're hopefully praying that these children are in school and not active, I think this has shown us that they are actually active, and they are active in the places where we thought they were safest. So what is the programming in that area so that we don't continue with the current data that we are getting around? I'm excited to hear about the male involvement now, which must also be addressed. Because if you have, is it 8% of those who are not using under the influence, it is the men taking that decision, then how do we mount a program which really encourages, empowers the men to be part and parcel of the contraceptive decisions that we need to use so that we reduce on these persistent high levels of unplanned pregnancies within our community. Actually, Uganda has one of the highest unmet need for even postpartum, almost 69% next to Afghanistan. Well, that indicator is really horrendous. How can we be next to Afghanistan in terms of unmet need for postpartum family planning? I think there are things which now we really need to say, but why? What is happening to us? I know that Ministry of Health, for instance, is now seeing how can we improve the quality of care in family planning. And I think this is going to be a priority area for all of us. The women vote with their feet. They're not coming because the quality, probably, not probably, because now we know our type of counseling, we are not giving them information on side effects. Some of us are also not able to manage the side effects. They are being referred to where they cannot reach. That is all spelled out now in the Ministry of Health's family planning checklist, which will empower health workers to address those things which we are not doing. And so I would also want to congratulate the Ministry of Health with this strategic direction now, realizing that quality also applies very much to family planning services. I hope 12 months from here, we shall begin to see some changes. I don't see why a health unit should not have a speculum and a sponge holding forceps to pull out the IUD. So I think there are questions, and I thank you very much, Chair, for giving me this opportunity to talk about this pillar one. Family planning is pillar one for us to improve the health of men and women, and in particular, the women and adolescents of Uganda. Thank you.
Thank you, Dr. Olive Sentumbwe. Very passionate about family planning. And what makes me happy is that the government has made one of the commitments is to increase method information index, which measures the information you give the lady about the side effects, the options available. So it's one of the focus areas for the Uganda 2030 commitments. Let me now invite Dr. Bukenya.
Thank you.
In a few minutes, or 1 minute, to give us his take on the presentation.
Yes, thank you, Chair. First, I would like to thank my brother for the good presentation. But also, before I proceed, I bring apologies from the chair of the Health Committee. The committee is doing field activities out of Kampala, I think part in Lango and another part in Renzori. So I'm sitting in for Dr. Ayume. I'll talk about 3 issues briefly. One, for the young people, the teenagers, the age of onset of sex vis-a-vis the age of onset or first encounter with contraceptives. And I'll leave it there. I think I'll challenge my brother, Reverend Semgoma, to think about that one. Secondly, for traditional methods being increasing in popularity, even in Kampala here, versus the modern methods. What is making it that way? Is it the side effects? Is it the marketing? Then the last point about long-term methods like implants versus the injection. The discontinuation of implants, I mean injections, could be because of the ease. And then people maintain the implants or long-term methods because of lack of technical abilities. I think that one should be looked into. It could be the one giving us that statistic that they may want to run away, but they can't easily access the service for discontinuation. Thank you.
Thank you, Dr. Bukenya. Let me now ask Richard Obeti, Dr. Richard Obeti, a DHO, to give us his perspective.
Yeah, thank you very much. In the first place, I want to thank the presenter, Simon, for the good presentation. I think in his presentation, what touched me was there are issues which touch the facility, especially the facility preparedness to offer family planning services to our clients. And also, he touched on the commodities, very key to real service delivery, because you can't offer service when the commodity is not there. But I was very impressed that he said the data he presented is not the latest, that he's going to invite us for the latest data. I'm just very hopeful that the picture we're going to see in his latest survey could be a little bit better than what we have seen here. I'm saying this because over the past 1 year or two, there have been some really good strides towards family planning. First of all, we want to really appreciate the ministry for the one facility, one warehouse policy. This policy has changed, has turned around things. It has made facilities responsible and have owned family planning. If you came to a government facility, maybe probably 1 year ago, we talked about the family planning, probably somebody will tell you, you wait for the outreach team of Maristops because they have the commodities. They are going to come for the outreach with the commodities. But that has changed. We now order these things through our system, and actually the outreach team comes and finds the commodities at the facility. And the good thing with this is that the missed opportunities we talked about, that a mother who gets a chance to reach a facility for a service is no longer pushed to wait for the outreach team to come. There's a immediate team that is there. And on that note, I want to really appreciate the Maristops because what they have done through the public sector strengthening. I know Simon talked about public sector strengthening, but I want to say I'm talking on behalf of Bunyangabo because the picture in Bunyangabo, it may not be the same in other districts, but I can say over the last 1 year, we have worked with the Maristops to really strengthen the capacity of the public sector. What we have done is, one, we have worked with the Maristop team to train our health workers on how to order, to implement this one facility, one warehouse. If you came to Bijangawa now, you have teams that can order and estimate these commodities, which is adequate for our clients when the service is done. Secondly, we have also gone ahead to train our staff, the midwives and the doctors at the Health Center 4 and some high volume Health Center 3s to offer these commodities so that if a mother came for implant, which we're talking about here, we don't have to wait for an outreach team to come, maybe in 1 month's time. No, the mother has to be served there and then. So I feel the picture is changing, and it has been good working with the Maristops, especially on the public sector strengthening. Now, what do we need to do? I think what the gaps I see is one, I think Doctor talked about it, the focus. A few days ago, Maristops supported us to develop district costed implementation plan. And when we are meeting with the stakeholders, one silent issue which came up was the focus, that we are focusing so much on women for family planning, and yet the people who are impregnating them are left untouched. We men, we have the capacity to impregnate women throughout the year, but the woman who is impregnated can only stay 9 months to get pregnant again. So, indeed, that course there we have men who on rampage. So the focus was, should we only focus on women when we talk about family planning, or there should be deliberate effort to actually involve men so that they can understand this? We have also had situations where actually women who finally get to facility without the consent of the husband also ends up in domestic violence, which is another problem for this woman. So I think that is another area where we need to really put more emphasis on. Another one is, of course, you saw in his presentation that a number of the commodities, even though ordered, were not delivered. I think around 41%. It was around 41 up to 47%. These commodities were ordered, but they're not delivered. So I think we need to do at the Ministry of Health level, at the National Medical Store level, at the warehouse level, can we be able to now quantify the needs of the country so that when facilities are going to order, actually we find these commodities are available at our sites. The last one is going to be, of course, equipment, Simon also mentioned it in his presentation. It is true, we have still some gaps of equipment. I think we need to now have these equipment available as a part of health system strengthening capacity in our center. Thank you very much.
Thank you so much. Yes, Dr. Jotham.
Chair, thank you. I asked to give information because our colleague here has made some statement which is very encouraging about availability of supplies in districts and other places, and especially working with the Maristops to improve on the way they get their commodities. I just wanted to give extra information, and since members of parliament are here and the Minister of Health is here, I think generally availability of contraceptives in the country is starting to be good. The good news is that we are getting more donors are giving us more commodities, but also government is also putting money in some of these. It should be putting in more on reproductive health commodities. Obviously, they need to do more. But generally, the situation is improving, and some of you who have an opportunity, especially members of parliament, if you have an opportunity to go and visit the national medical stores, you should do so and see what is going on there. Take an interest because you vote money, substantial amount of money there, and you should be seeing what they are doing. I have a conflict of interest here because I chair the board, but the good news is that what he's saying is happening in some districts, not because only Maristops, but the Minister of Health is encouraging them. National Medical Stores is partnering with the districts to make sure they improve on their procurement. What happens is that the drugs they get for contraceptives and others, it is them, district has to requisition for them. So they must know how to quantify, estimate what they are going to need for the year, so that and then they ask the national medical stores to supply them, because Parliament sends the money for those drugs to national medical stores directly. So for them, their job is to requisition. So if they don't requisition very well, then they will not get the right drugs. But also, if national medical stores does not deliver the right thing, then there would be a problem. So we need to continue watching that along the line. And I think national medical stores is also partnering with some districts and Ministry of Health to make sure that there is training for the in-charges of health units so that they do correct quantifying for the year, and so that they can do good ordering and make sure they get the right thing. So I thought I should bring that out. And since I'm still on and I may not come again, just say that, Simon, you talked about the, I know you, the appetite for children. Why do people have appetite for children? That's how you said it. So the way to dampen the appetite for children in the country is along these lines. First, you educate the women and not only give them skills, but they get into the formal employment, not informal. Informal is not as good as doing that, because when they go in the formal sector, they realize that the children being pregnant is competing with the way they want to be in the job. Banks, they want to become managers, so there will be a competition. So there you make the child very costly, and so our women will start not wanting to have many children. So that is one. The other one is also government related. Government must make sure that our children do not die. When children continue to die, many children die, the families perceive that they know that their children are threatened, so they continue to want to produce many. But if I know that if I produce 3 children, all of them will survive, then I will be looking for 3 children, I stress them out. So there are ways of tackling this issue, and all this is really related to what are your policies, policies in education, policies in employment, but also, again, policies at the level of making sure that the jobs are there for these women, but also health care is there so that infant mortality goes down as much as it can. Uganda is on a good trajectory in terms of child survival. We have reduced infant mortality, but it's not enough to impact meaningfully on the level how many children can have. But if you use those, you'll get there. You'll get there. Thank you.
Dr. Jotham, I think my colleague in CSO, I'm not give you we are running out of time, but I'll ask a different question. And the background to this presentation is that COVID came in and caused significant downstream issues to do with availability of commodities, accessibility to commodities, and it had an indirect effect on mortality, morbidity for our community, more especially the women. So you as a person from a civil society, what is the role of civil society in promoting SRH, especially within this COVID period? What do you think would be the role of civil society in promoting sexual reproductive health and rights during this period?
Thank you.
In 3 minutes, please.
Okay, I'll be brief, but I just would like to say one thing about the presentation, though. For me, this presentation just brought out one thing that we already know, that information is the biggest gap that we have. And unless we become aggressive on providing health information to the community, that's the only way we will be able to change this trajectory. And the main issue is that we are very shy on where we should provide information, the sources we should use. You see the traditional healers, now they get strategic junction, they put some small speakers, and everyone who is passing there is listening to them. So they have been very aggressive in making sure that their information reach the community, and that's how they're influencing people to take their service. And I just want to say one thing, even to the service providers, our great service providers like Maristops. You see, when you serve a client and they go into the community, they are going back to the community that has all the misconceptions about family planning. So the strength that that client has to stand for family planning is the quality of information that you have given to them at the point of service. And that's where we have a missing link as even the civil society, and that's where we have missing link as the service providers. We have to be aggressive on that, make sure that as part of the service, when the client is leaving your facility, they are well equipped with information regarding the service. But coming back to the issue of the COVID-19 pandemic, for us as the civil society, we are really trying to adopt. And the emphasis that we are making for us, the coordinating entities like the Sexual Reproductive Health Alliance, is first to start with the capacity. We are emphasizing to the civil society that make sure that your peer educators, your staff, but even the service providers understand the new normal that we are dealing with and are able to provide information to the communities, both about the COVID prevention, but integrating it with the issues of sexual reproductive health. We have been pushing for integrated approach. We know COVID has come, but we have challenges that we have been working on for decades, like the sexual reproductive health, access to family planning. So we cannot divert from those. We must use integrated approach. And so we are also pushing our civil society members who are providing services and information to make sure that they support government effort for COVID prevention, for COVID vaccination, but push for integration of sexual reproductive health information and services within that response. The other issue that has come up with the COVID for us, the civil society, is that the issue around digitalization. We have to find a new way of offering services, new way of offering information to the communities, to the young people. And so it has really challenged most of our civil society. Actually, we are prioritizing this area as a major area of capacity development in the coming year. Because most of the civil society partners do not have capacity. to deliver this information on digital platform, but also to use digital platform that works, for example, for the rural population. How do we still get someone who is in the rural area, say in Karamoja, in West Nile, to get information? Otherwise, we are only going to, if we focus on TV and radios, we are only focusing on the population in the urban. And yet, from the statistics, we have a lot of work to do in the rural areas. So that is a challenge that has been thrown at us, and there are a lot of innovative approaches that are coming up.
Yes,
that we would like
3
to
minutes
document.
are getting over.
Thank you. I just want to end with one thing. And this has come again with COVID, the issue of some of the key stakeholders that we work with. The leaders, I'm happy that we have members of parliament here. I'm happy that we have our religious leaders here. What COVID has really brought is that now more than ever, we need to work together. The time for blame game is over. We have to work together. We have to support each other and make sure that every platform that we have in the community, whether it's political or religious, we integrate COVID and SRHR information into that. That's the only way we will benefit our communities and reduce this risk that we see.
Thank you so much, Charles. I'll go to a young person, Joan. Uganda has been experiencing a high teenage pregnancy for some time. The EDHS has always put it at between, I think, 22 and 24, and even it went up and came down by 1 percentage point. COVID has really accelerated teenage pregnancies. You as a young person, what should government do, or what should government be doing to address the increase in teenage pregnancies? And what would be a call to action?
Okay. So, as a young person, first of all, I appreciate the fact that you have recognized the alarming cases of teenage pregnancy. Like, they are not even in 10s or 20s or 30s or even 100s, but they're in thousands. Like, next we know the cases of teenage pregnancy are going to be in millions, and I do not know if people actually understand the depth of these figures when we look at them in context of how many young people are going to be able to finish school, live up to their fullest potential, and things that are associated like that. So I believe, first and foremost, government needs to look at teenage pregnancy as a priority issue and as a development issue. In context of where we are heading, especially when government comes up and sets targets and says by 2030 we want to achieve middle income status. By let's say 2060 we want to be at this place. How do you want to be at this place and yet you're not prioritizing the growth of young people, you know, or the health of young people? And these people are going to get pregnant. When they get pregnant, it means their futures are actually, their futures, I don't even know how to elaborate it, their futures go to a standstill. So it actually means they can't gain a certain level of income because they are not educated enough. They can't be able to earn a particular level of income, as I said. So it's important that government, one, prioritizes access to sexual reproductive health in terms of policy formulation. How are the existing policies, for instance, the National Sexuality Framework or the National Schools Health Policy, how are they working? What is the context within which these policies are being implemented, you know? Because most of these policies actually exist in books, but the institution heads do not have critical understanding of them or how these policies will affect teenage pregnancy in the larger picture. So it's important for even parents, religious leaders, and cultural leaders to understand these policies, but also for legislators to educate themselves on the importance of these policies. Because for me on a personal level, I feel like we don't accord the importance there is to teenage pregnancy. Like Daily Monitor will report there are 1,000 cases of teenage pregnancy, and we are shouting, oh my God, teenage pregnancy is bad. But in translation to what we are doing, in the day-to-day, for instance, in the midst of the COVID-19 pandemic, how is government coming up strongly to say teenage pregnancy is wrong? Therefore, we are going to allocate a supplementary budget to tackle teenage pregnancy in the wake of COVID-19 because it's an important issue, you know? That would speak to the depth of how government prioritizes, one, young people as the future, but also basically prioritizing women and girls in context of achieving gender equality and other SDGs.
Thank you so much. I think we should clap for her because I'd never thought of a supplementary budget to address teenage pregnancy, but it's really an important point. We need resources to address teenage pregnancy. And since we have supplementary budget options, honorable members, Bukenya are here and others, please, let us see how we can include it as a supplementary because it's an urgent issue. And I like the fact that she's saying if Uganda is going to be a developed country in 20 years, 30 years, they are the ones who shall need to be in the chair doing the work. And if they are pregnant now, they won't be as productive, and Dr. Joseph Morris talks about that. Thank you so much, Atwire. Let me go down to the district level. You've had teenage pregnancies, you've had issues, the data that has been given. Can you give us examples of innovative approaches that you're using at district level to address increasing maternal, newborn, and child mortality, morbidity? Please, in 3 minutes.
Yeah, thank you very much. At the district level, I think what we are doing now is the multi-sectoral approach. We have brought on board, especially the community department, which for long has been working alone, because we realize they are the people who are actually on ground to work with the young girls who are affected by this issue, and also the CBOs that are working at the community level, you find they are directly involved. Besides that, we have accelerated also offering the maternal and, of course, the reproductive health services through partnerships with the groups like Maristops and the other groups, other CBOs and NGOs, where we organize integrated outreaches to reach out to women who may not be able to reach to the nearest health center 3 with services. And this includes both the mobile clinics, which we talked about here, and we also have static facilities like health center 2s, where we actually camp there to offer additional service to women who otherwise will walk a longer distance to reach a nearest health center 3 to get such services. For the neonatal care, I think the issue has been building capacity of our midwives who are particularly charged with the responsibility of looking after these young babies when they are born in the health facilities. And we have had a very good support from Ministry of Health as far as capacity building is concerned. And also they have given us some additional equipment for that purpose. Thank you.
Thank you so much, Dr. Richard.
Yes.
Let's come now to WHO. WHO has gained space in the area of supporting countries to develop guidelines, policies, protocols, standard operating procedures. And Uganda has done a good job to domesticate and adapt to these policies, guidelines. In just 3 minutes, Dr. Olive Sentumbwe, how can Uganda effectively utilize these guidelines to reduce maternal mortality rate? We know that the maternal mortality rate is decreasing, but not at the rate at which you want it to be. So how can we effectively use these tools to accelerate decline in maternal mortality rates?
Thank you, Chair. I think basically we are great as Uganda in terms of policies and guidelines, as you say. But we must place these guidelines within the 7 building blocks of the health system. Many of the things have been mentioned. And in order for the health worker to be implementing the standards that have been described and the how, again, which is described, we need to ensure that the health worker, let me start with the health worker pillar. That health worker, the human resource which we have, and they are different for maternal mortality. There are many cadres there who we have to ensure that we've recruited, we've distributed them to where they need to be, and that we are paying them, and they are staying on duty, and we are reducing absenteeism on their side. A lot of maternal deaths are in the rural areas, but we are also seeing them in Kampala. I give Kampala because that is probably the biggest unit we can think about. Even in the world, by the way, our unit for maternity is the biggest in terms of deliveries per day. Production line is very high. So we need to make sure that the numbers are right. They are matching the growing what? Population. They are available at the time when we expect them to be there, and they've got the right mix of skills, and they're working as a team to provide that integrated service. Because this woman fails here, she needs to make sure theater is ready. Theater must make sure that there is an anesthetist. There are nurses there also working. So that human resource gap must be critically looked at and improved on. But then these people are working within an infrastructure which must also be conducive. This has been really very obvious in the COVID-19 period, where we really need to talk about the space and the structures that we need to cater again for these high numbers of pregnant women who are having a very high fertility rate, which is increasing our burden in the health facilities. So that infrastructure needs also now to be addressed. Is it adequate for the very highly increasing population of Uganda? And can it serve what is required? If we go to the health center force, for instance, which we want to make sure that they're nearest the women, to what extent has that infrastructure been developed to address the services you want to put in there? But that needs finances. You need to increase the investment for the health service infrastructure, for the human resource gap, and you also need to increase finances to ensure that the medicines that are required for women to survive are also there. You do not have an opportunity to say, we have a stock out of Pitocin, for instance, when you know that every woman will require what? Pitocin at delivery. So you know that the highest mortality now is PPH, due to PPH. Do we have enough blood in all the regional hospitals and centers that are distributing? So we will have to make sure that this is in place, and we'll have to make sure that we engage the community, by the way. It's another arm for us to make sure that we build also, empower them. They know that they have to come, and they have to come in time. Doing community programs is not cheap. And so we also have to increase the investment in empowering our communities to want to be healthy. And that is going to take out a lot from the leadership, for instance. The government leadership, the community leadership that is at district level, they need to also develop their own leadership skills, accountability skills, so that they are mobilizing their communities into the health system. Of course, we need data systems to know, as Simon has presented, this is the issue here, this is the issue here, we need to prioritize this area. Data systems are also expensive, but they need to be utilized so that we are accountable for the results we are getting, and that we are prioritizing the areas which seems to be black or red for that matter, so that you respond according to the vulnerabilities and where they are. So I think the policies and guidelines cannot work by themselves, except we invest in the system in which they operate. Thank you.
Thank you so much, Dr. Olive Sentumbwe. I usually don't like diluting people's statements. I'll leave it at that. Members have listened. I think we cannot have policies without the other environment taken care of. I'll go to Honorable Kenya. Uganda now, we've made progress in achieving modern contraceptive prevalence rate. And if you look at projections, if we continue at this rate of increase in MCPR, and I think Dr. Jotham also maybe is aware of it, right now all women contraceptive prevalence rate is at 30%. For us, Uganda to reach 50%, it's going to be in 13 years if we continue at 1.5% increase. For married women, our contraceptive prevalence rate right now is 38. Let us say 39%. For us to reach 50%, it will be in 10 years. We also know that once you reach 50%, the donors will start reducing support for the family planning program. They start weaning us off the support. And we know that right now the family planning program is highly supported by donors. At a 9.6% total expenditure rate from government. And can I say, I don't want to, Dr. Jotham is here, National Mobilization Council, but the health sector is receiving less resources. And once the health sector receives less resources, that means family planning also receives less resources. My question to you is, how can we get more funding allocated to health, in particular reproductive health, in Uganda?
I think this is a fairly difficult question, but I'll start with where we started. The president usually talks about immunization, that he has immunized all the Bazukulu. And now we are doing better with child survival. And one of my favorite speakers said that immunization is for those children, but it plays the same role of family planning is immunization for the adults. And it does the same effect in reducing mortality and other things. And that is where we should start the agreement from, that family planning is as important as immunization. But our biggest challenge is that, like we are seated here, we are preaching to the converted. And we are likely to remain in this room. And you know, always, Dr. Lara and team bring their budget, and with $1 trillion as unfunded priority. And it looks like all of us have accepted and have become aloof to the effects, the end game, the final product of reduced use of contraceptive is partly maternal death. Afterwards, you have a lot of mortality. Then you also go to what Dr. Jotham talks about, school dropouts. If I asked in this room how many people have died over the last 2 years, I'm sure I'll get the number. Someone will press a button and get the number. And I'll also be sure to get a number of those who have been hospitalized because of COVID. But if I asked how many women have died because of maternal-related conditions, maternal death, I don't think someone can hazard a figure. For the last 2 years, Dr. Laro can use the standard of 16 per day and do the mathematics and give me. and those who have been hospitalized because of maternal-related complications, that one will be very difficult to catch the figure. So it means we haven't given these issues the space they need. At the peak of COVID, which has killed less people than the maternal deaths, at every news bulletin we would get 2 people from Kabale, 2 from Chiriandongo, 5 from Iganga, and even at the community level, the sensitization was there. And so everyone would pick interest at their level what they can do. And also government has come of cutting budgets and other things to allocate towards the COVID fight. So we are all used to what we need to wake up and give reproductive health the space it needs. If every morning at Capital FM would hear that 20 women died yesterday when they were delivering, one was because there was no blood, another one was because the doctors were not there, another one was because so-and-so didn't take their wife to hospital on time, then we shall funding and response. Because when you go to fight, when you are cutting a cake, every issue is and the competition. But give reproductive health the space it requires. Because we don't give reproductive health the space it requires, then that is why we get unfunded priorities, and mothers die every day. 16 avoidable deaths per day, and 2 people die of COVID, and the whole country is on high alert. So what aren't we doing well? Is it that we are not sharing the data? Is it that these ones were used, people should die, God has called them? Because during COVID, there have been a lot of innovations. Even Nambole was opened, even what? Ambulances are driving people from Kasese, from Moyo to Kampala. But now with these mothers dying, there is nothing that is being done. Because there are many other priorities, and we are not all of us are responsible here. If we can get our dashboard and every morning we know that these people have died, these teens have become pregnant, these ones died while procuring abortions, then everyone who is responsible for allocating will wake up and go where they are supposed to go, and we shall find a solution to this problem. Thank you.
Thank you, Honorable Kenya. Dr. Jotham, my mentor. Uganda has, at global level, we are moving from FP 2020 to FP 2030. And I'm glad to announce in this room that our own Dr. Olaro Charis is now a board member of the FP 2030 at global level. So that shows how the global community appreciates Uganda, particularly Ministry of Health, and as well as Dr. Olaro. And Dr. Olaro has steered us, along with Dr. Jotham Singuzi, to develop the FP 2030 commitments, which were launched, I think, 2 weeks ago. So that's a milestone. And we believe that Uganda commitments for FP 2030 are going to accelerate and catalyze the improvement in our MCPRI indicators. But Dr. Jotham, what does that mean to a normal Ugandan? How will a normal Ugandan gain from FP 2030? Secondly, how will the private sector and civil society organizations contribute to attainment of the Uganda commitments that were made for FP 2030?
Thank you very much, Moses, for that question. But before I answer that, let me take it from where Honorable Dr. Bukenya has left it, that our own countries, and it's not only Uganda, we have delegated the role of looking after our reproductive health needs to donors. The donors are willing, or we persuade them to continue supporting us. But then ourselves, our governments, and members of parliament, you need to hear this, we are not contributing as governments as much as we should do to these very important issues. Of course, I do not know whether it is because these issues of reproductive health, mainly we concentrate on the women. By the way, if I may tell you a story of a long time ago, I don't know how many of you ever heard it. When we started in the 90s, when we started talking about reproductive health, defining it and all that, we kept saying that in Uganda, we lose about 15, 16, 17 women per day out of pregnancy and childbirth. So maternal mortality ratio in Uganda. So it translated into real daily loss is about 15 women per day. So we started saying that in our countries, that is equivalent to like 10 losing some 10 Boeing aeroplanes. We started with aeroplanes. That 10 Boeings falling and killing all the people. Then the people of the Boeing, the ones who manufacture the plane, they said, we don't want you here using planes because then you scare people. People will know people are dying in the planes. So they stopped us from using Boeing as an example to tell the world what is happening to women of the world. Then my younger sister here is telling me that we started using minibuses as well and things like that. But the issues of reproductive health has unfortunately not got the support, the advocacy that they require. We are making noise here, we are talking about this, we are doing advocacy. But the point is that it needs more than what we are talking about. True, in Uganda, like 2 weeks ago, the Minister of Health launched the FP 2030 commitments. And to answer your question, yes, for government, what really government wants now is to see that there is increased access to family planning by all the women who need it. How do you do that? You make sure that the policy environment is correct. And I think, as we have heard, Uganda has good policies, not well implemented sometimes, but the policies are in place. But we need to continue making sure we hold government accountable on these policies. The policy environment to cover both public and also the private sector, civil society, must continue to be good and enabling. So that is a thing that we must do. But also government must continue to fund, again, the question that we are talking about. It must continue to fund adequately reproductive health, and these commitments, as pronounced in the commitment we launched, we need to make sure that the funding is indeed there and is adequate and not unfunded priorities, as the Honourable Member of Parliament has said. It's also important that, and we heard, I think, from the districts as well, that the reproductive health commodity security is an important aspect. It involves not only procurement and storage and distribution, but it also means that we must be, and I think Moses, we have been an expert on this, the quantification, that our health workers are able at the health unit levels and district levels, working also with those that procure, we are able to quantify what we need so that we are able to have adequate amounts of supplies and commodities for this. And then obviously, as we have also said, all the players make sure that things like myths and misconceptions are also eliminated from the minds of those that are meant to be using this. So together, if the government can increase funding, the policy framework is good for both the private sector, civil society organization, the donors and all of us. I think that way we stand a very good chance of achieving our FP 2030 commitments.
Thank you, Dr. Josam Singuzi, and thank you, the panel. I want to say, I'll not repeat what people have said, but I want to say that family planning is a right. Everyone has the right to access the commodities. You have the right to access full information and the right to access the services. We are glad that Maristops is spearheading that journey, providing these services. And I want to say, I know it's controversial, but a woman has a right to choose whether to have a child or not. It's a choice. And I want to say that we are proud of Maristops for the good work that you're doing. And the leadership by Dr. Caro, and also Dr. Jotham, I think the chair of the board. No? I've always thought like that, but it's okay. So thank you so much, and thank you for the panel members. May God bless you. Now we can go back and take our seats.
Thank you very much, Moses, chairing this session, and thanks for all the panel members. We are now coming to the end of our day in terms of this event. I want to take this opportunity again to thank everyone who has come in to be part of us in recognizing Maristop's presence in Uganda, where we've been, where we are, and where we want to go. I will encourage us to get the closing remarks. Please feel free as we go for lunch to walk down to the booth. There are a lot of questions on public sector strengthening. We have a booth which specifically speaks to that. But walk through and then get more details on what Maristops does. At this moment, let me take this opportunity to invite Dr. Ral, who is the Director of Clinical Services, Ministry of Health, to give us our closing remarks and to close this activity. Dr. Ral has been very central in supporting us, in making sure that we reach out to the last one. Dr. Ral, thanks and welcome.
Thank you. Our honorable members of parliament, representatives of our partners, both donor and implementing partners, representatives from the private sector, the Director General of the Population Council, WHO, the team from Maristops, the districts who are our forefront workers, NGOs, members of the press, ladies and gentlemen. First of all, it's my honor to be with you partly this morning and this afternoon as we look through Maristops Uganda Partnership Day 2021. I'm also happy to note that my minister was here in the morning for a full 2 hours. And I'm sure she should have said many other things which probably I would not want to do to repeat. But nevertheless, first of all, I had to ensure that I had to come here. Today we're having our joint review mission today and tomorrow. And I was also asking Carol why she's not attending. And I hope after this she will definitely be able to join. So all of you, It's also unfortunate I missed the presentation, but I've got the glimpse of what was presented this morning, which has been the basis of today. So, distinguished ladies and gentlemen, it's really my great honor to be here. And particularly as for the Maristops Partnership Day, organized under the theme of sexual reproductive health, post-services, post-COVID, and how do we maintain and scale up access. I think this is key, and as all of you have heard, that there is a glaring disparity between the rate of the child and maternal health across all the quantiles, and we would want to change this picture so that it really would not be that we are saying the same things every day. Members have echoed here of the 15, 16 mothers who die every day. And we are closely waiting to look for the incoming demographic survey, which will be able to give us. But nevertheless, I want to do mention that at the Ministry of Health, we do conduct a maternal and perinatal death surveillance report or review almost every week. And beginning from the beginning of January up to now, the information which we have is that we've lost about 689 mothers. Those are the ones who have died in the what? In the institutions. Actually, in the week of the 42nd week, that's in November, on the 2nd, we lost 17 mothers. And we know which facilities where we are what? Where we are losing these mothers. And so that now gives me an average of about 16 mothers per week from the 15 mothers per what? Per day. This might not be able to cover all of them, but at least gives you a picture that it might not be as gloomy as that which we are touting every day. So I just want to give that with all those ones now, what should we be able to do? I think that's what's more important now, that what should we be able to do? First, but probably before I say those 3 or 4 things which I want to emphasize, I want definitely to applaud Maristops. And probably if you could join me to heartily clap for them for all the contributions which they have been able to work. There is no doubt they have been in this space. And for the rest of the other members, they even went ahead now, they have a maternal hospital. I don't know whether the members are aware of that. There's a maternal hospital which is allocated in Forest Mall. So you should be able to see how we can be able to increase these services. So they have, in addition to all the other aspects which they have been providing in all the other clinics, they have gone now to see how they can be able to provide those services. So one of the key issues that working together as partners is to ensure a well-coordinated and a well-integrated approach, and we shall continue to prioritize efforts to reduce maternal mortality. We are aware that most of the direct causes of maternal mortality is hemorrhage, 42%. And last week, though we had gone to Soroti to launch the COVID vaccination, but I participated on behalf of the peers to hand over the site for a construction of a regional blood bank in Soroti. So we think that the Soroti region should be able to have a blood bank in the next 12 months. We're also working on see that there's a blood bank in Arua so that it addresses the West Nile aspect. But as we're waiting that, in addition to what is there currently, we're also functionalizing the blood collection site in Navy Hospital, and we're trying to work on that. And we'll work on one also in Kabale, so that the issues of availability of blood is improved. The other second issue which we think we need to work together is to increase contraceptive prevalence rates. And if you do that, for you to address the first one, the maternal mortality and all that wanted, you have to be able to address what? Increase the prevalence of contraceptives. And this is one of the key pillars of safe motherhood. Really, among the 6 pillars of safe motherhood is really to address aspect of family planning. So we need to increase contraceptive prevalence to lessen and this will lessen maternal and infant health risks by preventing unintended, as you heard from Moses, unintended, the 4 out of 10 who have got unintended, and closely spaced pregnancies, as well as contribute towards reduction of teenage pregnancy rates. The third aspect is to increase the post-abortion care services. So if you structure all the different age groups, if you look at the young age groups, whereas hemorrhage will remain as the major cause of death, but closely following up is the issues of infections, and most of them come from aspect of abortion. So because of unwanted pregnancies. So if we can be able to address that, I think we could be able to close the gap. Because we really need to close the gap. So this intervention needs to be strengthened by all partners who can contribute towards the achievement of maternal and child health in Uganda. And we want to applaud the contribution of Maristops and all our partners, which make the sector through different programs. I also want to take note and advantage of the availability of members of parliament, and we think that all of us have got a very key role. And I note what Honorable Bukenya mentioned is that when we come to these boardrooms, we speak to the converted. We need to get out of this, so that, and then we need to be able to see that we get the village health teams, so that these commodities are available at the village health one. In addition to education, strengthening health workers, but these services are available. So we need to get out of the boardroom and be able to be seen in the community. But at the same time, whereas we preach the gospel of modern contraceptives, we also have to be seen to be practicing, because we will not be able to have the moral authority to be able to tell the people that we need to reduce the number of children when they have, when actually that you have probably with this lady, this number of children, and then the other one you already have. So that if you have 9, then you have, and each one now you say, now I will have 2 on each one. When you actually they are what? They become 9. Whereas for the mother, they are low, but they will still have a strain on the population. The other aspect, in aspect of addressing equity, is definitely we would want that we reach the hard-to-reach areas, the humanitarian settings, like where there are refugees, and so that they can be able to access. So outreaches will still remain a major element of service delivery in that aspect. So the public outreach models and public sector strengthening of program funded will be able to assist us that. So as I conclude, I want to applaud the effort of all partners present, including development partners, donors, child society, for the role you have played towards increasing access to health care. When they launched the state of the Ugandan population, you remember very well that was threatened to reach by 105 million people by 2050. So it's got implications on what the development which we are talking of. As the young people mentioned here, that if we don't address teenage pregnancy, keep the children the girls at school, and definitely also the boy child at school, then we will not be able to convert this. So as a ministry, we applaud the long-term partnership with all of you on several projects, partial milestones, and definitely would want to applaud the team lead, because leadership is key. So Carol, and we as a ministry and as the head of Maristops, we take cognizance of the leadership you are providing to Maristops to work with the Minister of Health. So ladies and gentlemen, it will be good if all of us who are in this room become champions. I think that's the last aspect which I want to mention. so that we will not be talking of just Josa Musingers. We will have that all the people in this room were champions of family planning, or family spacing, so that we can be able to talk the same thing. Even if we are talking of anything else, integrate messages on family planning in whatever we do. So it's my pleasure to close this session of Maristops Day, Partnership 2021. I mean, this is 2021 as we look forward to 2022. Thank you very much for listening.
I think members now will go for lunch at the poolside. The coupons for lunch are at the entrance where we are registering from. Again, thank you very much for honoring our invitation and being part of the partnership day today. Wish you all the best. Enjoy your lunch. For those who want to continue going to the booth, please feel free even after lunch. We'll be in here. But I'm going to request Dr. Carol to drive our guests to the Maristops banner there for a group photo. And then thereafter we can go for lunch. Thank you very much, and enjoy your lunch.
Hello, excuse me members. Let's pray for the food and for our departure. Loving Father, we come before you to say thank you so much for this time that you have given unto us since we started this meeting. Lord, we thank you for the organizers, Dr. facilitators, and we thank you for all those who have been here. Lord, it's my prayer that you bless the food that is prepared before us, so that we can eat it and get energy to continue serving you.
Maristops Uganda has consistently delivered high-quality sexual and reproductive health services to Ugandans. We deliver health services through various channels, including our 15 clinics, which offer general health care, sexual and reproductive health, antenatal care, and family planning. We are evolving to serve you better through our new highly specialized hospital and maternity located at Lugogo Forest Hall. The hospital adds to our nationwide portfolio of 15 clinics and exemplifies our evolution to walk with a woman, her health journey, from the menarche through childbirth to menopause. Our range of client-centered services include maternity services, antenatal, delivery, and postnatal care. To support safe delivery, the Maristops Hospital and Maternity offers maternity obstetric services, including antenatal care, exceptional delivery care, and postnatal care. We also provide newborn and infant care, including vaccinations, gynecological services, including treatment of fibroids, infertility evaluation and management, cervical cancer screening, and treatment of precancerous lesions. Services including family planning, post-abortion care, and management of STIs. General outpatient care including COVID testing, comprehensive laboratory services, diagnostic scans including 3D. We are open 24/7 and have a standby state-of-the-art ambulance to respond to emergencies. Our contact center team is on hand to receive your calls toll-free, provide information, book your appointments, and follow you up. For more information, call our toll-free number on 080-022-0333 or contact us through our website on www.maristops.or.ug. Visit us today to experience exceptional healthcare. 30 years, Maristops Uganda has consistently delivered high-quality sexual and reproductive health services to Ugandans. We deliver health services through various channels, including our 15 clinics, which offer general health care, sexual and reproductive health, antenatal care, and family planning. We are evolving to serve you better through our new highly specialized hospital and maternity located at Lugogo Forest Hall. The hospital adds to our nationwide portfolio of 15 clinics and exemplifies our evolution to walk with a woman, her health journey, from the menarche through childbirth to menopause. Our range of client-centered services include maternity services, antenatal, delivery, and postnatal care. To support safe delivery, the Maristops Hospital and Maternity offers maternity obstetric services, including antenatal care, exceptional delivery care, and postnatal care. We also provide newborn and infant care, including vaccinations, gynecological services, including treatment of fibroids, infertility evaluation and management, cervical cancer screening, and treatment of precancerous lesions. Services including family planning, post-abortion care, and management of STIs. General outpatient care including COVID testing, comprehensive laboratory services, diagnostic scans including 3D. We are open 24/7 and have a standby state-of-the-art ambulance to respond to emergencies. Our contact center team is on hand to receive your calls toll-free, provide information, book your appointments, and follow you up. For more information, call our toll-free number on 080-022-0333 or contact us through our website on www.maristops.or.ug. Visit us today to experience exceptional healthcare.
Hello, I'm Tobias and I work here in Uganda for CBM. Today I would like to take you on a quick tour